know and to know what we do not know. That is true knowledge. Let's move on to the first session of the day, fee paper presentation. The moderators for this session are Dr. Sunil Dikshit, Dr. Sunil Sharma sir. I request the moderators to come on stage, and I request Dr. Danesh Kumar to present his paper on safety and efficacy of levosimendan in severe LV dysfunction in patients undergoing CABG.
Good morning, chairpersons, ladies and gentlemen. My paper is on the safety and efficacy of the levosimendan in the severe LV dysfunction patients undergoing CABG. The aims and objectives of my study was that levosimendan is a calcium sensitizing immunodilators. It has very narrow therapeutic window and dose-dependent side effects in the form of hypotension and arrhythmias. Keeping these things in mind, we studied the safety and efficacy in the Indian patients with the severe LV dysfunction undergoing CABG. The material methods. It was a prospective randomized double-blind study in the 50 patients of the coronary artery bypass disease with the severe LV dysfunction patients. Patients were divided randomly in the two groups. One group A received the levosimendan and the group B received the placebo. The placebo is the injection vitamin B complex solution to match the same color for the 24 hours along with all the regular cardioprotective medicines. It's not changing.
Where is the pointer?
The material method in the inclusion criteria were all CAD patients who are undergoing electives OPCAP and having the LVEF of less than 35% and who gave the informed consent. The exclusion criteria was the patients who was requiring emergency surgery, hemodynamically significant arrhythmia patients, bundle branch block patients, and the patient who was having any ECG deformity in form the LVB or RBB, patient having anemia, any hepatic dysfunction, and any unstable angina or pulmonary dysfunction, patient in whom the full drug cannot be computed because of the hypotensions or arrhythmias. So we excluded them from the study. The patients who required the redo CABG were not taken the study, and patient required institutional insertion of the IAP or the prolonged preoperative inotropic sports were also excluded from the study. Please change from there. Okay, next. This is our well-matched patient demography. Change. The results of our study was we found that it's safe and well tolerated in our patients. The hypotensive effects was less likely when we avoid the bolus dose, and it give it in the low dose infusion in the patients having the systolic blood pressure less than 100 mm of Hg. We found the significant hypertension in 3 out of the 28 patients in the group A, and there is no difference in the hospital and the ICU stay, and there was no mortality benefits. None of our patients complained of the nausea, vomiting, dizziness, and headache. We found atrial fibrillation in the 10% of the patients, and the premature ventricular contraction in the 17% of the patients following the levosimendan infusion up to 48 hours. This is the chart showing the group A and group B, the mean blood pressure changes during the 48 hours till 48 hours post-off. There is definitely fall more in the group A as compared to the group B because of the vasodilatory effect. There are, from the past 20 years, this drug is in the market, and there are multiple studies like LIDO, Ruslan, LEO-RAP studies. We studied already the safety and efficacy of this drug. After that, this drug was launched in the Indian market. And there was also studies like Survive-1 and Survive-2 who studied the safety and efficacy of this drug. And they also found the hypotension as a primarily adverse effect. The Jaguszewski J et al. In their meta-analysis found that there is reduction in the hospital stay and the mortality after using the levosimendan in the intermittent infusion. The Papjed et al. In the 20 years of levosimendan, they found there is a better effects with the levosimendan as compared to the dobutamine and the milrinone, and the safety was also superior. The Wong B et al. In the meta-analysis found there is reduction in the death and the adverse outcome with the levosimendan. Jyotinath K et al. Found this drug is non-inferior to the milrinone following the cardiac surgery, and the Guarnosino F et al. Found this drug is safe and very effective anodilator in the cardiac surgery. The Silvetes et al. Found there is the decrease in the hospitalization while using the levosimendan drug. The Sanfilippo P. F. et al. And Abed, there are multiple studies which shows there is no effect with the levosimendan, and this drug is there is motility benefits are underpowered or unambiguous or neutral or insufficient, and we know studies to confirm it. In conclusion, levosimendan is a safe drug when used cautiously in the low dose infusion under monitoring. Adverse effects are due to its vasodilatory effects, especially when the loading doses are used. The motility reduction is still underpowered. Currently, this drug is not available in the market from past 1 or 2 years. These are my references. Thank you.
Thank you very much, Dr. Danes. Some queries regarding this drug, levosimendan. Levosimendan is available in India. We are using for last 2 years
Okay.
in SMS Medical College here.
Okay.
The queries regarding that this study may be better if this drug is to be compared with other inodilator like dobutamine or milrinone, so that we can understand should we use this drug over the milrinone or dobutamine. Number one. Do you have any idea regarding this question?
Yeah, I know because the benefit on the left ventricle function is already proven because of this drug. So some patients may say why we are not receiving the benefit of the levosimendan when we have it. So why we will receive the dobutamine instead of it, because this drug is superior to the dobutamine. So we should receive the
This is my question. That was my question. That are there studies or your experience regarding levosimendan versus dobutamine or milrinone?
This is Lido study,
Or
which is
milrinone.
comparing the levosimendan and the dobutamine, and the levosimendan is better.
It's better than
Yeah,
dobutamine. And over milrinone?
And over milrinone also,
It
there
is-
is a survive study, and other studies are there.
Okay. Then second question is in this type of subgroup of your patient with CABG in less than 35% EF, do you have the viability test for these patients with myocardial PET scan or thallium scan?
We do assess our patients with the 2D echocardiography or the TE
Okay.
in the post-op patient till after the 48 hours, and we check the LV parameters and the RV parameters, which are denoting the LV function or RV functions, and we see the improvement in these parameters.
Before surgery. Before
Yeah,
surgery,
before surgery,
do
this
you
study-
evaluate your patients with PET scan or thallium?
No, we don't check with the PET scan or thallium. We rely on the 2D echocardiography
Okay.
and the 2D echocardiography parameters, and we start this drug in the preoperative period, 24 hours before the surgery, and we complete it before the surgery, and the study continues and it goes till 48 hours, and we assess intraoperatively our patients with the 2D echocardiography, Swan-Ganz parameters and the vital parameters, and we say at the same time we also record the adverse effects also.
Okay, thank you very much, Dr.
Thank you.
Danes.
You are not using levosimendan under when you use IABP. But
Yes.
when the ejection fraction is less than 35, what criteria
I
you are
know.
using to put IABP and using that
Ma'am,
thing?
actually, that's because that these were the exclusion and inclusion criteria, and we are stick to it. But
Nahin,
because
at
the
what
same,
time you decide that this patient is going for IABP and this is not for this thing? Because see,
Yes.
when the ejection fraction is less than 35, prophylactic also, I think in your institution, IABP is instituted.
Yes, I know. ma'am.
So
I am telling you, I'm just
Yeah.
This drug is also called pharmacological IAP.
Okay.
So when our patient, which are stable patients with 35% of ejection fraction, we initially tried this drug to improve the function. If this drug failed, we insert the IAP.
Okay.
Okay.
Okay. Thank you
Okay.
so much
Okay.
for your.
Thank you, ma'am.
Okay,
Thank you,
Dr.
ma'am.
Danes, thank you very much.
Thank you.
And now I would like to invite Dr. Jitin Sankar to present his study regarding the outcome of patient with severe LV dysfunction less than 30% EF undergoing isolated coronary artery bypass surgery. Over to Dr. Jitin Sankar.
Good morning, everyone. I am Dr. Jitin, coming from GKNM Hospital, Coimbatore. Next, please. And first of all, thanks to XCon 2022 for giving me an opportunity to present over here. And I don't have any disclosures. And as we all know, coronary artery disease is one of the most leading cause of heart failure, which accounts for 60 to 68%. And preoperative LV dysfunction is a well-known risk factor for the intraoperative and perioperative mortality. And role of CABG in this subset of patients is studied in the landmark trials like STITCH trials. But there are less number of literature from Indian subcontinent. So our aim is to assess the short-term outcome of patients with severe LV dysfunction, EF less than 35%, 30% undergoing isolated CABG. Objectives of my studies were perioperative mortality and morbidity, that includes length of ICU stay, duration of ventilation, need of IABP or any other mechanical circulatory supports, MACE, and renal dysfunction. And on the follow-up period, the follow-up period was 1 year. Over the follow-up period, we studied the change in left ventricular function by ejection fraction and improvement in functional class by NVH. It's a prospective longitudinal analytical study conducted between 2016 to 2018 in our center. And all the patients undergoing isolated CABG with ejection fraction less than 30% were included in the study, provided this patient had evidence of viable myocardium either by MPA scan or by a PET scan. And exclusion criteria were patient with concomitant procedure, LV aneurysm, significant mitral regurgitation, emergency CABGs were excluded. And the mean age of my patients were 61, and majority of the population were males, and 73% had diabetes mellitus, and 19% of the patients had preoperative renal dysfunction. 4% of the patients had preoperative CVA, and 71% of the population had previous MA. Majority were had anterior wall MA, and 5% of the population had underwent percutaneous intervention before. And the coronary artery disease, 27% of the population had left main disease, and majority had triple vessel disease. And the mean ejection fraction was 28.41%. And majority of our study population were in the NVHA class 2 or 3, only 12% were in NVHA class 4. And 53% of the population underwent off-pump CABG and rest underwent on-pump CABG. Coming to the results, we had an in-hospital mortality of 5%. 1 patient had a postoperative CVA, 8 patients had postoperative new onset of renal dysfunction, and 2 underwent dialysis. 9% of the population required postoperative IABP, and atrial arrhythmias, we observed 14% of our institutional usual, less than 2% were the incidence of AF. And ventricular arrhythmias also were high in this subset of patient, which accounted for approximately 7% of the patient. And mean ICU stay was 3.12 plus or minus 2.4. And we followed up this patient for over a period of 1 year, and the follow-up mortality was 4%, and rehospitalization for cardiovascular cause, including heart failure, was seen in 3% of the population. And this is the ejection fraction, mean ejection fraction over the follow-up period of 1 year. We got this patient at 1 month, 6 months, and 1 year, and we assessed the EF by transthoracic echo, and the mean EF you can see at the 1 month is 35, and the preoperative mean EF is 28, and at 6 months it is 37, and at 1 year 41, with a significant mean difference of 13% over a period of 1 year. You can see the same trend in this chart. You can see the pre-op EF of 28, and after 1 year the mean EF is 41. And this is the stacked bar diagram comparing the NVHA class at the end of 1 year, and you can see majority of the patients at the end of 1 year were either in NVHA class 1 or NVHA class 2. This is the association of clinical parameters with the mortality. And you can see there is no difference between off-pump versus on-pump in the mortality. And the use of postoperative IABP, you can see the odds of mortalities were 7 times higher than the patient who did not require IABP. And coming to a little bit about literature search and the preoperative patient's characteristics. In our study, the hypertension 45% and diabetes mellitus 73%, which can be comparable with the other studies. This last one is a stitch trial population demographic, and their constitution was 59% had hypertension and 39 had diabetes mellitus. In Indian population, we had more of diabetes patients, accounts for 73%. And the in-hospital mortality in various studies. In our study, we had an in-hospital mortality of 5%. And you can see the other trials also, which is very much comparable. To summarize my points, the mean difference in EF was statistically significant in all the time periods, and there was a great improvement in NYHA functional class. Majority of the patients were in NYHA class 1 or class 2 at the end of 1 year, and preoperative NYHA class 4 and postoperative requirement of IABP were independent risk factors for mortality. In-hospital mortality was 5%, follow-up mortality was 4%. To conclude, CABG can be performed severe dysfunction with low short-term mortality and morbidity, and leads to an improvement in ejection fraction. Yes, this study also has got its own limitation. It is a small sample size of 100, and it's a single center study. Though LVEF is the strongest predictor for mortality and morbidity, other clinical factors also cannot be underestimated. Any complication during the follow-up period also can lead into the mortality, and there is no validated comparative group. This is only the patients underwent CABG with less than 30% were included in this study. A multicentric study with longer follow-up with a higher sample size will give more evidence in this regard. Thank you.
It is your thesis. It is
Your thesis? Yeah.
This study is your thesis.
This is my thesis. Sorry.
You did not mention anything about mitral valve status.
We excluded those patients with severe mitral regurgitation. Only mild to moderate MR with doesn't need any intervention only were included in this study. Excluded the severe MR patients.
What was your primary objective of this study?
Over the period of 1 year, what is the mortality in this subset of patient and morbidities, including the postoperative ICU stay, CVA, renal dysfunction, requirement of dialysis, and the secondary objectives were to assess the ejection fraction over a period of 1 year in the subsequent follow-up period.
So, according to you,
NYHA functional class.
ejection fraction improves.
Yeah.
After CABG.
Yes.
How much?
13% mean difference is within a period of 1 year was proven in my study, and all the patients had a preoperative viability scan. Yeah, we did viability scan for all the 100 patients.
Very good presentation, but a little bit questions like if you have done viability test before the surgery, what was the status regarding the LED territory or RC
Yeah, in our
territory? And in that territories, is the function improved if the viability test showed that there is a hibernating myocardium?
Yeah,
What
the
is
first question, we have done a viability scan for all the patients, and our institutional policy, more than 50% viability in the LED territory, those patients only we have taken for CABG. And those patients, to assess the improvement in the viability in that area, we haven't done any cardiac PET or MRI scan in the follow-up period. Only by ejection fraction and NYHA functional class, we have assessed the postoperative improvement in their status, functional as well as EF.
How much PET scan cost at your hospital?
Our hospital, it's approximately, our hospital doesn't have a PET scan. We have to send the patient outside. We do MPA scan in our center. In my study population, 72% had an MPA scan. Only 18% of the population had a PET scan, which we refer to a nearby center and get back the patient.
Cost?
It is 14,000 for the PET scan.
And you, what is the exclusion criteria that in PET scan, if there is non-viability in LED territory,
Yeah.
then you
We
selected these patients?
No, we
or not?
haven't
Okay.
selected this.
And what is the average number of grafts in these patients?
Average number of grafts was 2
Number of two.
or 3.
And we don't have any comparative study in this subgroup of patient with the stenting. If
No,
the viability
no, I
test
don't.
is
I haven't done the comparative study with the percutaneous inversion.
okay.
What was the predominant presentation of patients? Angina or dyspnea?
It's mainly angina. In these patients, mainly angina. Few patients, only 12% of the patient had NYHA class 4 symptoms. And majority of my patients were in NYHA class 2. 38% had NYHA class 3 symptoms.
predominantly patient populations were consist of angina patients.
Angina. Very few had dyspnea.
And acute MI.
We haven't taken emergency CABG, acute MI revascularization.
But because in our experience, if patients comes to you with a long standing MI or long standing CAD, then usually EF does not improve despite of very good grafting or very good number of grafting. So, and patients are complaining with dyspnea, not angina.
And
If patient is complaining angina, then obviously
the
EF can be
myocardium-
improved by the CABG.
I think
But-
angina indicates myocardium is viable.
My guideline is viable.
And
That
this is
so there is a controversy that if PET scan is showing that the viability is not present in that cases and patient presenting with dyspnea, then they are not going to improve. In those patients, stenting can be done or patient should be maintained on medical management. Oh, okay, but your group is of acute angina or acute emergency CVGs with low EF. Then
emergency we haven't done.
Obviously, then CVGs should be done. Very good. Very good
Actually,
presentation.
there is
Thank you.
already there are multi-center RCTs available, like you have heard of SWITCH trials,
Yeah, yes.
successful studies,
Yeah.
which are purely
Government sector में तो आती ही नहीं ना।
severe iodine dysfunction patients and with the enrichment patients. So there is already this fact is proven, there is benefit to the CABG. So this study is done on the Indian patients.
Yeah,
So
yes.
this is the only plus point for you.
Thank you.
Okay, thank you very much, Dr. Jitin Sankar. Now, I would like to call Dr. Anil Babu to present his paper on the early Indian experience in robotic assist coronary revascularization. Over to Dr. Anil Babu.
Okay, good morning, one and all. I would like to share our early Indian experience in robotic assist coronary revascularization. It's a single center study. So we know robotic assist CABG did come from around, it was there since 1998, and dedicated centers around the world have constantly developed and improved their technology. It did fall out in India for almost a couple of decades, but it's slowly picking up. So the aim was to assess the impact and outcome of robot assist CABG of 2 years application of institute. And the method was, it was a retrospective analysis of prospectively collected data. So the major indications were single or multiple vessel coronary artery disease and multi-vessel coronary disease using a hybrid approach with PCI. So some of the important criteria that we took into consideration were like obese, immunosuppressed, smokers, and poor respiratory function, as well as elderly with comorbidities. So the absolute contraindications according to our study were like pleural symphysis and inability to tolerate single lung ventilation. And related contraindications are like significant cardiomegaly, severe obesity with intrathoracic adiposity, intramyocardial coronaries, and previous cardiac surgery. So imaging, the cross-sectional imaging is obviously very important because for the maneuverability of the instruments, the camera port entry side to the pericardium has to be at least 1.7 centimeters, as well as the AP to transverse diameter should be more than 0.5. So this is how the positioning is. The robot will be in the right side of the patient. Instruments will be placed in the patient's left side, and bedside surgeon and scrub nurse will be on the left side. So the docking can be either left or right based on the based on the conduit that is going to get harvested. So this is my professor sitting with the console very comfortably, and this is the docked arms. This is how once you take out the middle incision will be expanded to do the distals. So what are the benefits? Basically, the articles like Wang et al. In 2014 European review article, as well as Bonatti in 2016, the JTCVS, they have stated that improved precision, range of motion, extended arms 360-degree, magnified HD vision, a better cosmetic output, reduced pain and length of stay in hospital, reduced risk of infection and bleeding. But obviously, there is a need for conversion to an open procedure if it demands. Shortcomings were they were relatively younger patients. The number of grafts was relatively low, and there is a long learning curve. So our data at Apollo Hospitals, we have done 136 patients till January of this year. And the mean age was around 61, and hospital stay average was around 5 days. So most of our patients belong to the age group of 50 to 70. Good LV was there for around 75% of the patients. Average Euroscore was 2.8. The hybrid robot assist was done for around 43 patients and robotic assist was done for 93. Conversion to sternotomy did happen to around 5 patients. 3 were because of inadequate Lima flow, and 1 was because of calcified LAD, and 1 was because of deep intramyocardial LAD. So most of our patients, like initial stages, we could only graft 1 distal in the first 1 year. Thereafter, we improved to around 2 to 3 per case. So bilateral internal membrane artery was harvested in 65 patients. Average number of distals performed is 1.6. Average ICU stay is 2.5, and ventilators hours almost 10 hours. So we managed to get most of our patients out in the second post-op day. Just would like to quote few wordings from certain articles like Fadi Hamal in Canadian Journal. The perioperative outcomes like MI, AF, stroke, and renal failure were almost comparable with the conventional CABG. Significantly shorter ICU stays and less pain. Also, they say that there are similar outcomes when it comes to angina, graft stenosis, failure, and need for revascularization. So some of the other, one more quote I would like to say from Hussam Balke, JTCVS 2021. What he says is the dexterity through robotic approach is very superior. The exclusion criteria for them was basically the need for an emergency surgery, severe LV dysfunction, and a fused left chest from the previous surgery. So what we conclude over here is like the robotic assist CABG meets the current safety standards and is a reasonable alternative. The initial application in a low risk group of patients and followed by a stepwise approach towards a completely endoscopic versions of the operation would be ideal. And despite a high grade of innovation and steeper learning curve, it is essential technique in the spectrum of treatment methods for coronary revascularization. Thank you.
Thank you very much, Dr. Jeko. Anish Babu.
Thank you, sir.
One question is that before going on the robotic assist coronary CABG, is it necessary to have some experience regarding minimal invasive cardiac surgery and minimal invasive CABG?
Yeah. So
Or directly anyone can switch from the conventional CABG to the robotic assist CABG?
so there are 2 schools of thought. According to my professor, he says you should have a good minimally invasive exposure, at least some 200 to 300 cases. Thereafter, you can go ahead with robotic. But there are few people who says that we can directly also jump into robotic, provided it's just like if you're really good in computer games and stuff, especially PlayStation. So there it is something like that. So in the long run, certain people have a knack of catching robotic at a faster pace. Especially what I would suggest is like elderly, I mean, not elderly, like surgeons who are into their 70s, who do face the trouble of tremors. They can definitely go ahead with robotic surgery because it is very gentle for a surgeon. You can sit peacefully and do your procedure. There is tremor filter is there. So I suggest, like, according to my professor, he suggests definitely we need a minimally invasive exposure.
And for our Indian experience, as your studies, so what is the difference between the cost of the conventional surgery and minimal then robotic cardiac surgery per patient?
Yeah.
If you count them for a long time, including the cost of robot and other items.
Yes, sir. So in our
What is
hospital,
the difference?
we charge double the price of a conventional CABG for a robotic procedure. For example, if in a normal procedure for a private patient, if it is around 2.5 lakhs, for robotic, we are charging around 5.
Okay, then it can be possible.
You perform them routinely.
Yeah, so last 2 years, we have managed 136 patients. So if you take in the last 60 days per se, we have done almost 45 procedures. So the awareness is really improving and we are managing to do around 4 to 5 per week now.
And do you have long-term results?
So it's just 2-year data. And I told you like 5 patients we had to convert. Apart from that, we do follow up the patients. Of the patients follow up so far, they are doing good.
And what are the reason for conversion? What is the reason of conversion?
Yeah, 5 patients we had to convert. The thing is like of the 3, it was in the initial 6 months of our robotic experience.
Because
There,
of difficulty in surgery.
no,
Because
we
of
did
difficulty in
harvest the
surgery.
Lima through robotic, but the flow was inadequate. So we had to go
Lima
up. And
flow.
then another 2 scenarios, one was the calcified LAD and one was very deep intramedullary LAD. So these 5 situations we had to go for.
And is there any difference between the overall quality of surgery and number of grafts of surgery?
In our first 1 year, we could manage like 1 or 2 distals, and mostly we focused on only harvesting lima. But in the last 6 months to 1 year, we are constantly able to do 2 to 3 distals, and results wise is reasonably better, sir. So it's a learning curve, so it takes time.
Yeah, obviously, any new thing required learning curve, but I just want to know that is there any difference between the number of grafts or the overall quality of surgery? Is
So
it is it better to go on conventional or minimal invasive
So I
if we
would
are
say, sir,
reducing the graft?
I would say definitely conventional is something really.
Is there any tendency, sir wants to ask, is there any tendency of undergrafting?
Sir, if we find that the patient requires a lot of grafts, we go for our hybrid approach where we will do a robotic assisted lima. Thereafter, we'll have to do a percutaneous intervention. But I do agree that conventional CABG is the gold standard for sure. It's still.
Because we what we facing for last 2 to 3 years, I personally have experienced that usually the patient required 4 grafts.
Yes, sir.
For at least 80% of cases required 4 grafts in my 2-year experience, last 2-year experience. So that I have done only 20 cases of with minimal invasive cardiac surgery, because it is very difficult to put more grafts by any minimal approach. So finally, I have to go conventional CABG for 4 or 5 grafts. So
I
this
agree,
is
sir.
the question basically, कि if we are going with robot or the minimal invasive, so is there any tendency of undergrafting? That what
We won't be able to match the conventional CABG, sir. But what I suggest is like being our specialty definitely is a struggling one. We should also, this is the most innovative technology available. We should have this also as an option. It shouldn't be like we should just ignore it. And like most of the younger budding surgeons, that has to be something more innovative, and we should have it in our resource.
Yeah.
Is there any difficulty in doing proximal?
So for us, all our grafting was like Lima 2 or Rima, no, sir. We have not gone for a vein graft so far. So
Lima radial Y, yeah, Lima Y.
Lima Y. So, sir, one thing, in case there are 3 ports, sir. The middle port we convert into like another 1.5 inch to do our distals.
So you
But-
are not handling aorta at all.
Yeah, anaerotic techniques, sir. But what I've been told by my professor is like the upper port, the upper working right hand working port, we can expand it in case to another 1.5 inch, in case the proximal becomes difficult.
So what is your selection criteria?
So selection criteria at the moment, we are offering it mainly for good LV patients with with very less comorbidities. We are just offering this for the patient. Like there are certain patients who say that they don't want any scar. I mean, almost the similar indications to minimal.
With regard to coronary,
Regarding coordinate.
with regard to coronary, double vessel, triple vessel,
See, like we didn't consider coronary with regarding to so selection criteria.
Huh.
Regarding
So
coronary.
initial stages we were focusing only on single vessel or double
Lima to
vessel.
LAD.
Lima to LAD in the initial 1
This is
year.
the best subset.
Yeah,
This is the
best subset because the gold standard, the territory, the main
But
territory.
sir, how many patients we get with single vessel
No, sir,
disease?
That's why I asked.
Excuse me,
that
sir,
Is there
so-
any possibility of undergrafting? Because in my last 2-year experience, I have put 4 grafts in at least 80% of patients. At least 80% of patients.
Yeah.
I just want to say this minimal invasive and robotic surgery is a gold, will become a gold standard for single or double vessel. This thing where
Yes.
you require triple vessel disease, I think conventional CABG is the best for the
At present,
more.
at present. But maybe
Yeah.
the future maybe the
Future,
So the problem is we don't have any study from India in based on robotics, sir. And as
Yeah.
far as I know, there are only 2 centers that do robotic, and it's like just budding stage.
Yeah.
But we should have this in our and as you said, sir, about the grafting. In the last 1 year, we are able to constantly take for 65 patients, we took bilateral, and we were able to graft 2 to 3 at an average. It's a learning curve, sir, and slowly.
Yeah.
Oh,
You are honest in your
Very-
saying that there was 3 patients there was inadequate Lima to LED flow.
Yeah.
So do you do the TTFM study or something? Which method you assign?
No, we'll do a conventional angio itself.
Conventional angio,
Yeah,
post-surgery,
yeah.
to assess the Lima flow.
Yeah.
And after that, you revise your graphs.
Yeah.
Okay. On-table angiography or after the patient discharge?
We don't have an on-table facility, sir. We don't have a hybrid room yet,
Okay.
but we have to. We do have a tie-up with our cardiology colleagues. So after the procedure, we just.
Yeah, definitely there is a suboptimal quality of the grafts and the number of grafts reduces with the robotic.
Yeah.
So do you face any difficulty while grafting the OM territory? Because that was a very, very difficult one.
Sir, but initially, no, we did graft OM, sir, but yeah, it's all like, as we say, the deep stitches and that extending the incision. Sometimes the middle port, we may have to extend downwards. Sometimes middle port, we have to extend upwards based on the territory. So what we do is like that 2 centimeter, which are already available, we'll just get a hang of it, take a deep stitch, and thereafter, we'll just analyze where we should extend the incision. Based on that, we'll extend the middle incision and go ahead, sir.
Thank you.
Okay, thank you very much. Very good information you provide us regarding the robotic or the minimal invasive cardiac surgery. Thank you very much.
Thank you, sir.
And now I would like to invite Dr. Pradeep for his presentation regarding the palliative sending procedure in Eisenmenger syndrome with transposition physiology patients. Over to Dr. Pradeep.
Good morning to all. I am Dr. Pradeep, consultant cardiac surgeon from MGM. I'll be presenting on sending as a palliation in Eisenmenger syndrome with transposition physiology. So I would love to start this with a case presentation. This is a 19-year-old male who came with, since ours is a high volume transplant center, he was referred to us for a heart and lung transplant from a peripheral center in Tamil Nadu. He's a 19-year-old male with grade 3 clubbing and severe cyanosis. And initial diagnosis was multiple large VSDs, and his AV valves were normal, and there was a good biventricular function with bidirectionally shunting VSD, and his room mass saturation in OPD was around 58 to 59%. And we subject him to cath study, and this is his cath report, where we can see his PA pressures are nearly systemic with 140 by 74, mean of 96. And this, you can see the PA saturation is 81, and his aortic saturation is 70. And there is some sign of reversibility with the PA saturation improving to 90.4% with the 10 liters of oxygen. And you can see the QP is also very high. And he is slipping into the Eisenmenger syndrome at this point of time. And he has been clinically in class 3 dyspnea and fatigability. And what we can see from this cath report is, this is the echo of this patient. You can see there's a multiple large VSDs and no AV valve regurgitation. And there is a bidirectional shunting across the VSD. What we can infer from the cath report is there is a halocline there, where you can see 2 streams of water running with no physical division between them, but they don't get mixed up. This is defined as halocline in oceanography. And this is what is happening in the heart now. So what's happening is there is a transposition in the Eisenmenger syndrome. So the blood is entering into the ventricular chambers, and there are large VSDs, but the direction of force is in such a way that oxygenated blood is slipping into the going into the pulmonary artery, and deoxygenated blood is going into the aorta. So what would be the palliation for him is transpose Eisenmenger physiology to convert the transposed Eisenmenger physiology to a normal Eisenmenger physiology. How could it be done? It could be done either in 2 ways. One is either by an atrial switch, other is by arterial switch. So what are the challenges we face? We face in arterial switches. It's technically difficult, and it involves coronary transposition, and there will be a great vessel size discrepancy. And atrial switch is more transplant friendly when they come for a transplant, as arterial switch can involve a LeCompte also. And definitely the CPB time is going to be prolonged for arterial switch, and it involves multiple blood transfusion. And of course, when there is a very high PVR, left ventricle is much preferred to pump against such high PVR. And there are a lot of ways we can bring down SVR, but only we have a very handful of medicines where we can control PVR. That too, patient may have to stay in the ICU for a long time in that case. So before going on, what are the prerequisites we needed is that the patient should have a good biventricular function, and patient should have a competent AV valves, and patient should have a normal systemic and pulmonary venous drainage. There shouldn't be any rhythm abnormalities, and no LVOTO or RVOTO. And as in this case, there should be a cath demonstrated difference in saturation between ATA and PI is at least by around 15%. And PA pressure should not be too like suprasystemic PA pressures, and there should be some sign of reversibility with the systemic, and PA pressure should preferably systemic or just subsystemic. So what are the precautions you should take during sendings? Is soon after you open the chest, you first confirm it, take a blood gas from PA and compare it with the ABG. You should be able to see the difference in the saturation. And before even soon after going on bypass, dissect the whole phrenic nerve from the whole length of the phrenic nerve, so that during sending you need not keep on looking on the phrenic nerve on every bite you take in the pericardium. And if intra-atrial septum is not intact, have a PTFA or bovine patch on the table. And during sendings, if never hesitate to unroof the coronary sinus to widen out your IVC drainage. And we would advise like keep a Hagar or a Quatrans tube into the SVC and into the IVC while you are reconstructing the SVC IVC pathway. There are multiple videos in YouTube where we can see how sending is being done, but I feel this is one procedure which is being currently re-emerging, and as a surgeon, it's always advisable to get mastered in this. So yeah, as you can see, soon after going on bypass, we put a nerve hook on the phrenic nerve and dissect the whole phrenic nerve from the pericardium. So the third layer, while you are doing sending, you can just do it faster. You need not keep on looking whether your bite has gone into the phrenic nerve. And this is the unroofing of coronary sinus to widen out the IVC drainage. We tend to put more caution onto the SVC drainage, but the IVC drainage is also equally important. And this is the post-op echo where you can see the SVC IVC back to the mitral valve and pulmonary venous drainage into the tricuspid valve. So where we can implement practices is this, as I told you before, it should be cath demonstrated before taking the patient onto the table, and it can be done for patients with multiple or single unrestricted large VSD with severe PAH, and URV VSD with unobstructed pulmonary blood flow, and patients with TGA VSD and with severe PAH. And after doing this, it's always better to have the systemic ventricle in constant surveillance. Systemic in this, usually after sendings, it's the systemic ventricle which it fails, but in this scenarios, it's when it fails, the both ventricles fail together. This is a study published in 2010 from Heart, Lung and Circulation, showing the long-term results of palliative atrial switch. Here you can see the patients are being followed for 30 years, and there are patients who have showed significant improvement in the 6-minute walk test from 367 to 614 meters, and their baseline saturation has improved from 50s and 60s to. So heart and lung transplant and sending, the sending's natural history is much better than heart and lung transplant. And challenges what we face in heart lung transplant is well known. First thing is scarcity of the donor, the cost involvement and complexity of the procedure, and the patient has to be on lifelong immunosuppression and lifelong surveillance. And only a limited centers have expertise in doing heart lung transplantation and managing patients in post-op period. So our experiences, we have done 6 patients of the similar clinical pictures, and all varies from age 3 to 21. 4 were males, 2 were females. PVR more than everybody had PVR of more than 8. Saturation was less than 70. Follow-up varies from 6 months to 7 years. Mean saturation is pre-op from 60%. It has gone up to 85%. And functionally, they are much improved from class 3 to class 1. And mean ICU stays average on an average of 7 days. Most common morbidity is pleural effusion. We have refractory effusion, like a patient need to be on ICD for a continuous 3-4 days in the ward also. And 2 such patients, and 2 patients had SVTs which were managed with amiodarone. And 1 patient had low cardiac output. This patient had a very high PVR with a suprasystemic PA pressure. That was the point we learned that we shouldn't go to the patients with a very high suprasystemic PA pressures. And fortunately, we didn't have mortality so far. And one of the patient got married, and he started a family and having a happy life now. And take-home messages, sending is a re-imaging procedure can effectively improve the quality of life in patients in these scenarios and can buy time before heart and lung transplant. Thank you.
Thank you very much, Dr. Pradeep.
Hello.
As you said that sending procedure is better alternative than the heart lung transplant in this particular subgroup of patient with Eisenmenger, but there should be step up of oxygen.
Some step up, sir.
How much?
Step up is, you mean post oxygenation?
Yeah, you
or difference in aorta and PA saturation.
What difference between aorta
difference at least 10%, 10 to 15%. Otherwise, patient will not have any clinical difference at all.
And in what perspective you said that it is better than heart lung transplant in this subgroup?
Sir,
what is
see, all these patients whom we have done, or like they are from underprivileged community. One is they can't afford. Second is considering the morbidity of the heart and lung transplant, and the amount of days they have to stay in the ICU and all, it's very high. And when we started, ours is a high volume heart lung transplant center. When we started counseling for a transplant, it's the first question they ask is how many days we have to stay in the hospital and chance of mortality. And these subset of people are all, they are all from daily wages community. They plainly tell they are even convinced for taking such high risk procedures, but staying months together in a hospital, compromising their daily wages and all, they are very reluctant. And we find a lot of patients has been left in the community just for the reason that they are all Eisenmenger and not manageable. And all these patients whom we are following, they are really very happy. The moment they see, they become pink. No, the feel is different. And functionally, they feel much better. The boy whom I presented is 19, but he has never gone to school after 5th standard. And he has been completely homebound. And now he is able to walk along with his friends, go to cinema with his friends. And he is feeling very happy. He feels as if we have given a new life. But we know that he has to be in constant surveillance. And at one point of time, he'll end up in heart lung transplant. But redo is like part and parcel of any cardiac surgeon. So that is not going to be an issue. So we thought we'll give them more time before they come up for a very big procedure. They should be mentally primed also before taking up such high morbid procedure. So we started doing this, and we are very patients are also feeling happy. We are also convinced that
okay. And you don't intervene the BHDs or any
we don't touch
primary
it.
pathology?
We don't touch it at all.
And
there is a case where there was an anomalous right upper pulmonary venous connection. So we did a Warden also.
Okay.
We did a Warden and mustard. But that was only one case.
Okay. Thank you very much. Thank you very much. Very good presentation, Dr. Pradeep. Thank you very much. Any query? Any question from the audience? No. Okay. Now I would like to request Dr. Dinesh Kumar to present her speech on the comparative study between the conventional technique and modified carvo dissection for the Lima harvesting during CABG patients.
Good morning, everyone. Today I would like to present on my study on a comparative study between conventional technique and modified carvo dissection for Lima harvesting in patients of CABG. So basically in CABG, lima plays the main role. In we use the lima to have bypass the left main of the stenosis delay and it's considered as a gold standard. And it's the most important factor in survival and in freedom from major cardiovascular events. So the conventional technique of using a Bowie's electric artery is always associated with the adverse effect of spasm, thermal injury, and avulsion of branches and dissection. So there's no more refined approach to mitigate all these adverse events. Therefore, to clear this event, so we devised a single study, like an use of a novel technique of use of carbo dissection. So basically, this study involves framing a new technique in which we use the conventional Bowie artery with the normal blower or mister we use while doing a CABG, in which the blower will be assured with the CO2 rather than normal oxygen. So we usually use the carbon dioxide in this study. So do not avoid the burns. So it is fastened by silk tie and it is combined here. So what are the advantages of using this? The gas dissection causes vasodilation and maintains the artery in a dilated state. So during the harvesting, and the saline flow reduces the amount of the heat generated, therefore preventing any thermal injury. So technique has been reported as a single case study in MMCTS. So based on that reference, we actually thought of doing it as a bigger study. So the type of study we did was a prospective randomized comparative study. So this video showing how the device has been made.
We usually do the fixation with ties at two sides.
It contains the blower along with the artery
so that
and the blower with the
fixation
mister
is
again.
stable. The blower tip can be positioned above the blade or slightly to the right or to the left.
It contains the blower along the mister.
What you
So this is actually taking the dissection there.
movements of the
So using the same technique to dissection the lima
gas
from the lima
helps
pedicle.
to separate the tissues easily from the
The
overlying
blower
tissue
actually
wall
dissects the tissue and we can
cleans
see a lesser
clearly
cautery
delineates
in the area
branches
of the
which are then
lima
divided
pedicle.
and
It actually
divided.
prevents charring also as an action.
Here, the working space created by carbo dissection is well visualized on either side of the branch.
So how to define the study? So we took to objectify the study, we took two parameters, that is a flow in 1 minute after dissecting the lima and the operative time required for harvesting the lima again. So between the two techniques. So calculation size, we took it as 46 based on the power of 90%, 23 in each conventional and 23 in modified carbo dissection. So inclusion criteria, we had an elective CABG and hemodynamically stable CAD patients. No emergency was actually taken because involving the learning curve again. Exclusion criteria, reoperation patients, previous sternotomy already done, already dissected lima, concomitant valve operation or complicated ventricular aneurysm resection, other additional major cardiac procedures, and patients with chronic obstructive disease. This is for the pleural harvesting. So after the IRB clearance, we took the 46 patients fulfilling the inclusion criteria and were randomized and the data was collected. The SPS data was used. Randomization was a simple randomization plan. And results, this was the age distribution. Both are almost the same, 58.17 and 58.6 in the both groups. With the forest plot between the age difference between the two age groups, between the two groups of conventional carbo dissection. And the operative time for the conventional was in 15 minutes 78, plus or minus 2.1, and carbo dissection is 15.48, almost the same operative time. And why I want to tell the operative time is almost not an advantage, but still it has actually compared the effect that the learning curve is actually attained, and it doesn't clear a difference again. And the flow parameter almost same, but things like there is a significant indication that the flow of taking the carbo dissection was slightly higher compared to the conventional one. So the power of study was thought to be about 80%. And conclusion, though it was not statistically much significant, the operative time when we take the parameter, the learning curve was a little shorter again. So the use of the technique can be used, and the flow was slightly higher in compared to the carbo dissection group. The only limitation we had was a smaller sample size. So this could have been tried to be done in a larger group to give a further clear-cut conclusion. Though carbo dissection has a point of showing that it has an improvement, so we can actually try this method for this one. These are my references. Thank you.
Thank you very much. Very good.
Thank you.
And one question is how much the flow of carbon dioxide in the blow during the surgery?
2 liters we kept, sir.
2 liters.
2
And
liters.
it is carbon dioxide.
Is carbon dioxide, pure carbon dioxide. That is the only cost-effective factor, sir. Even why we did this for harmonic scalpel is definitely a improved technique, definitely. But we are trying an economic one. Definitely, I'm from a government clinical college. So if that could have been used here, we were trying a technique like that. So in that way, so CO2 will cost, it is obviously used for VATs and everything. So we can use the same thing. So no new cost practice, but using the same technique and creating an economic one.
Definitely, it looks better.
Yeah,
It
sir.
looks better.
Yeah.
It is original work. Thank you very much. Thank you. Any query?
Yes, I think it is an innovation, but what is the advantage of CO2? It is just like a type of hydrodissection you want to say.
Yes, sir.
The pressure of CO2 creates a plane
Yes.
between the bone and the vessel.
Yes, sir. That's what we are doing. Then thing is like CO2 also goes vasodilation also.
My
So-
question is, vasodilation can be done by anti-G and papaverine as we routinely do.
Yes, sir.
So can we use simple air? Simple air.
Because it will burn. So that is why we use the CO2, which is inert towards the burning.
It may be a reason, but simple air has 78% nitrogen. But okay,
We can try.
okay. And can high pressure cause injury to lemur?
It can, sir. So, but in our study, we didn't find any complication on that. So, out of all thing, we kept it on normal pressure only, but thing on the pressure side is CO2, but we didn't find any injury on that
Okay,
complication.
thanks.
Thank you, sir. Thank you.
Is there any other speakers present in the hall? No other speakers. Jairaj, Dr. Jairaj, Dr. Harry, Dr. Neeraj, Dr. Tahima. No? Okay, then can we finish this session, scientific session? Okay. So, ready? Many. We use levosimendan for at least 2 years. Basically, anesthetist people. Anesthetist, madam gave the thesis to 2 students for the levosimendan use. And what our experience was that not better than dovitamin. It's like, look like almost the same results of levosimendan with the dovitamin. But it is definitely Melanon is the best drug for the as an iodide in our experience. Maybe long term rate maybe better of levosimendan. Okay. Maybe some more studies or more long-term results are required to prove this drug. Because any drug, any new drug are forced by the companies, by the so we had to evaluate their efficacies and the long-term results. So we all are industry driven, maximum more studies, maximum studies are industry driven. So
Speakers, please be here.
okay, all the speakers, please.
In a few minutes, we are going to give you the momentum. Stay there.
I would like to invite all the presenters to the stage.
All
and
the speakers
moderators
kindly
to
come on the stage.
This is ask Sunil and both the Sunils to give both the Sunils to give. Dinesh. Dr. Dinesh. We are next. have a break and have tea. By the time we arrange, we have the number to we all have
pleura is then tented over the residual lung tissue by suturing the border of the pleura to the lower edge of the thoracotomy. This will create a smaller chest space and hence prevent an apical space problem to the patient. Another method is a pneumoperitoneum. We saw a very good diagram yesterday from Dr. Rajan Santosham's team, wherein we can inject air into the abdominal cavity, causing elevation of the hemidiaphragm. This would again reduce the space and allow the lung to stick to the chest wall. Another temporizing measure is a phrenic nerve crushing, which is not a very well recommended method because it does affect the diaphragmatic movement. But yes, in dire situations, we can do a phrenic nerve crushing. Just crushing it with an artery twice or thrice is only going to cause a neuropraxia. It is not going to cause an exontemesis. It is not cutting the phrenic nerve. It is just crushing it temporarily, which will recover over 3 to 4 months. And this causes the diaphragm to go up. As the diaphragm goes up, the space reduces and the lung is likely to stick to the chest wall, reducing the problem of apical space. The post-operative important factors to be considered are, as in cardiac surgery, we try to keep the patient intubated for the first post-operative day. However, in surgery for bronchiectasis, we recommend that there should be on-table extubation always, unless it is absolutely not possible. Negative pressure chest drainage systems, like whether there are different brands available, we use the Medulla device, but any of these systems have significantly reduced our post-operative problems, whether it is persistent air leak or it is apical space problems. Early resumption of chest physiotherapy, both pre-operatively and post-operatively. Taking care of chest physiotherapy is the single most factor which can affect outcomes of these patients. Vigorous monitoring of a drain output if we have done a pneumonectomy, that in itself can reduce the incidence of vigorous monitoring helps us to identify if there is a bleeding and go in early. Early ambulation, again physiotherapy, and normal diet and medications to be resumed as soon as possible are critical to improved outcomes in patients with bronchiectasis. I thank you for your attention and I'm happy to answer questions.
Thank you, Pallavi. I think you are the best person coming from the National Institute of Chest Diseases for this talk. I think what you did not mention probably is the high complications up to 80% in the olden days was surgeons were busy to take them for surgery without optimizing medical management, without making them dry. However, dry them with medical management, there will always be some secretions which will spill over when you put them into lateral position. More so in the absence of WM and endotracheal tubes, which were not there when the complications rate were up to 80%. So there's a good improvement, not only from the surgical understanding, medical management, and also anesthesia management, which has helped to reduce the complications.
Very true, sir.
Like you said, if the complication rate is 20%, 50%, surgeon has to learn a lot because surgery is not the choice for them. Questions?
Ma'am, it would depend on a case-by-case situation. In case there is bilateral extensive bronchiectasis, we would not recommend surgery for these patients. If they have bilateral localized bronchiectasis and one side has a greater significantly purulent secretions or something, then we might consider that side surgery first. However, at the same time, it is important to understand that sometimes thoracoplasty might be the best procedure when there is bilateral bronchiectasis. Apical thoracoplasty can really help these patients.
About apical.
Yes,
I'm
ma'am.
talking if it is a low bronchiectasis, low bronchiectasis.
Ma'am, bilateral low bronchiectasis are generally due to sequestration, and we can do sequential surgery with a 3-month break.
Okay, thank you, sir.
Thank you, ma'am.
The advances in thoracic surgery which have decreased mortality, morbidity, as well as improved post-operative results. If one has to ask, single one most important, a good double lumen tube placement by anesthetist, which is monitored by pediatric fiber optic bronchoscope. That has prevented most of the complications. As the doctors already said, making the patient as dry as possible before surgery is very important. But you cannot make them 100% dry. Then no secretion has to go to the other lung. Second most important advance that we've seen is greater use of greater and liberal use of surgical staplers. But as she said, fissureless, if you make it by blunt dissection, more air leak was possible, and you can take a better control with staplers. And third is a greater use of digital portable suction device, because that has made suction possible, and keeping the decreased lung volume in a state of suction definitely reduces the incidence. That's what is my experience, and as well as many studies have told. These three advances have made a significant difference. That's why from a morbidity rate of 20%, 40%, we are now expecting almost 0%. And that should be the aim. And but it's an area which is still to be needs continuous improvement. About physiotherapy, I would also mention that one has to, there's a tendency among surgeons to be quite rough with the patient for physiotherapy. That's not needed. A very gentle physiotherapy, considering the patient, he should not be subjected to excessive pain because of physiotherapy, like hitting him here like this and all. Those are things which we studied in olden days. That is why it's better to have a more professional physiotherapist who spends time with the patient and does it in a gentle manner. And very important to teach physiotherapy before surgery rather than after surgery, because after surgery patient is in a state of pain, he will not understand physiotherapy.
Good analgesia also in the post-operative period that most surgeons forget to give.
But
that should be the rule.
And as surgeons, we should be very honestly comparing our results. Are we definitely improving or not? There's no point everybody showing 0% mortality, 0% morbidity in all the conferences. That is just not done. That's what I think I can use this forum to ask you people. If thoracic surgery as a specialty has to grow, we have to very honestly share our data. Everything. Nothing to be, hidden there, and everything has to be shown, shared, complications. That's why we will reach a state where we can expect almost 0% morbidity and mortality. Thank you so much, Dr. Pallavi. Thank you.
Thank you, Pallavi. Nikhil Rane, our colleague, is going to guide us in minimizing and management of air leaks following LVRS. Nikhil, please bring up his PPT, first PPT.
I'll be speaking on minimization and management of post-op complication, especially persistent to air leak after lung volume reduction surgery. I'll speed up in first few slides and then I'll slow down. There's nothing to disclose. Greetings from Apollo Hospital, Navi Mumbai. COPD. It's a collection of diseases which include chronic bronchitis and emphysema, which is characterized by irreversible obstruction, chronic obstruction of airflow. It was classified by global GOLD classification into Gold 1, Gold 2, Gold 3, Gold 4 in mild, moderate, and severe, depending on the FEV1 and percentage of it. With Gold 1 more than 80%, Gold 2 50 to 79, Gold 3 30 to 49, and Gold 4 less than 30. Etiology being smoking, industrial exposure, and alpha-1 antitrypsin deficiency. This pathophysiology, the chronic irritant substance causes antigen precursor cell, epithelial cell, and ultimately these mature CD8-4 forms performin and granzyme, which leads to emphysema or chronic bronchitis and hypermucus secretions. These are the symptoms: dyspnea, chronic productive cough, wheeze, generalized muscle wasting, acute infective exacerbation, and right heart failure. On signs: barrel-shaped chest, pursed lip expiration, prolonged expiratory phase, finger clubbing, JVP, signs of right heart failure, muffled heart sounds. This is a progressive gradual decline disease with punctate of acute infective exacerbations. For assessment, the body index, which include body mass index, airflow obstruction, dyspnea, and exercise capacity, as recommended by NICE guidelines. This is a chest X-ray showing emphysema with hyperinflation and flattening of both dome of diaphragm. The CT scan and VQ scan are used to assess this disease severity. The treatment of this COPD, the emphysema, is include medical management, endobronchial therapy, and surgery. In medical management, we use long-acting beta agonists, antimuscarinic, corticosteroids, smoking cessation, flu vaccination, antibiotic, pulmonary rehabilitation, and long-term oxygen therapy. Coming to the endobronchial therapy, it includes valves, injection of heated water vapors, endobronchial occlusion, and extra anatomic bypass. Coming to the main surgical part of my presentation, the surgical treatment offered to this emphysema is bulectomy, lung volume reduction surgery, lung transplantation, and management of complications like pneumothorax. In bullectomy, for a giant bulla, bullectomy is the treatment. Laser coagulation of bulla, Monaldi procedure and modified Monaldi procedure. In modified Monaldi procedure, the bulla is fixed to the chest wall and the bulla is open and a catheter is placed and talc is placed at the same time and allow it to expand. And later on expansion, the tube is removed. Now, the indication of bullectomy is the large bulla occupying more than 30% of the chest wall. With contraindication is pulmonary hypertension and hypercapnia. However, the bullectomy also has a complication of air leak. Coming to lung volume reduction surgery, which is made, now I'll slow down, but I'll finish within time. Lung volume reduction surgery is removal of 20 to 30% of lung parenchyma. It means most disease parenchyma where we target, so that a removal of the bulla allows, not bulla, but the bullous disease allow, it removes the non-functional tissue of hyperinflated lung, which it allow the normal lung to expand, which improves the mechanism of ventilation. It reduces the dead space so that the chest and diaphragm can return to their more normal anatomic positions, and reduction of lung volume, which increases the lateral elastic forces and it keeps the airway patent during expiration. Lung volume reduction surgery is a multidisciplinary approach in which the role of pulmonologist, nursing care, thoracic surgeon, chest radiologist, thoracic anesthesiologist, critical care medicine, respiratory therapists, and rehabilitation, they all work together. Lung volume reduction surgery indication, the severe symptomatic patient with bilateral heterogeneous emphysema with surgically targeted area, with surgically accessible targeted areas are the most suitable candidate for LVRS. Although this talk has covered previously, I'll go with the complication. Before surgery, as Pallavi said, the preoperative optimization is important. That is pulmonary rehabilitation program, deep breathing, coughing, incentive spirometry exercises, COPD management, and smoking cessations. These are to be 6 to 10 weeks before we take the patient for LVRS. The most important, like in day-to-day, we chart our roadmap before we proceeding to our travel. The same way we should have studied the CT scan before to the surgery, so that the resection margin can be anticipated before. The LVRS approaches are median sternotomy, VATS, and bilateral thoracotomies. Coming to the complications, these are complications. I'll divide into the anesthesia related and surgical related. I'll just enumerate. I'll not go in detail since my talk more on air leak. So the anesthesia related is pre-op, intra-op, post-op. Surgically also pre-op, intra-op, post-op. The post-op again divided immediate post-op and delayed post-op. The pre-op complication I'll just enumerate is acidity, anxiety, sleeplessness, and in case of private setup, a financial burden. The complication of LVRS are air leak is the most common, pneumonia, cardiac complication, arrhythmia, thromboembolic diseases, gastrointestinal morbidity, pneumonia, and empyema. However, prolonged mechanical ventilation support is required. However, mortality, according to the NET trial, is 90-day mortality is 7.9%. Sound of wind. Sound of wind, if we hear on a hill station or a deep sea, it's just so romantic. However, but sound of wind bubbling through an ICD, we get a catastrophic feeling. So air leak. Air leak is defined as a leaking of air lasting more than 5 days, according to the thoracic surgery database of Society of Thoracic Surgeon. Its incidence is in other surgeries 9.7 to 15% in lung resections. However, it is 90% in case of NET trial in a LVRS group. It is the most common complication, and usually the air leak occur from lung parenchyma, staple line, or suture lines. And also it is, as Pallavi said, in bronchial stump. Air leak. The Cerfolio is classified into grade 1, grade 2, grade 3, grade C. Grade 1 being during forceful expiration only, that is on coughing. Grade 2 expiration only. Grade 3 on inspiration, and grade C on continuous bubbling during inspiration and expiration. The management of air leak. we evaluate the air leak in 3 parameters, that is volume, duration, and trend of air leak. A small air leak with a gradually day by day decreasing trend are likely to resolve spontaneously. However, the large leak doesn't showing a decreasing trend is unlikely to reduce. So if there is small leak, lung expand, occlude the tube, keep the patient under observation, repeat and chest X-ray. If expanded, remove the tube. If lung collapse, subcutaneous emphysema develop, remove the clamp, Hemlich valve can be used. Whether to connect an ICD, the ICD to the underwater seal or a digital suction device. As said, digital suction device is helpful, but while in case of lung volume surgery, no, the water seal is used. However, in the other studies where Sarfoli et al. Says underwater seal give early drain removal. Brunelli also says what underwater seal and suction is equal, where Aked et al. Says in his randomized control trial, there is no suction in no suction group, early drain removal is possible. We monitor the drain output, and depending on that, we take out the decision whether to remove the drain or not. The patient who has persistent air leak and who's cannot candidate for further intervention, a talc fluorosis is a substitute. Autologous blood patch can be used, where in 50 to 100 ml venous blood of the patient is flushed to the ICD, and it will cover up the area of a air leak and decreases the air leak. Bronchoscopic procedure like sealant sclerosant implanted devices are used. I'll discuss in detail, and surgically re-exploration. There are consensus statement, but there is no guideline on persistent air leak on post-surgical persistent air leak. These are mentioned about persistent air leak after secondary causes. The endobronchial wall. These are the wall which allow secretion and air to flow out of an occluded pulmonary segment during expiration, but prevent any distal flow of air during inspiration. So these are deployed by endobronchially. The principle followed during bronchoscopic management is the localization of airway, localization of air leak, bronchoscopic sealant, and one-way walls or placing. The first step in localization is the most crucial, tedious, and it is complicated by the distal collateral ventilation or incomplete fissure, because the others non-leaking segment supplies the air leak. Air to the disease that goes difficulty during localization of the air leak. So selective balloon bronchial occlusion is the method where a balloon is passed into the bronchus intermediate, and we observe the intercostal drainage tube output, either underwater seal or digital suction device, and we see if there is an air leak, continuous air leak or not. If it ceases, we deflate the balloon and go to the another segment, and subsequently we localize the air leak. If sometime happen after giving anesthesia, the air leak ceases. In that case, endobronchial oxygen insufflation, as suggested by Weil and colleague, can be used. The third method is installation of methylene blue through the intercostal drainage tube and observing which bronchopulmonary segment is gets stained. So the sealant used are fibrin glue, cyanoacrylate glue, albumin, glutarate, hydrogel, sclerosant. These are used for small air leak in bronchopleural fistulas. Sclerosant like ethanol tetracycline, endobronchial implant, endobronchial spigot, and endobronchial placement of vascular embolization coil plus or minus sealants. So bronchoscopically place one-way wall. They allow air and secretion to escape, prevent air from entering occluded bronchial portion, partial volume loss of blocked portion of lung, and it decreases the flow through alveolo-pleural fistula. These are initially used for lung volume reduction, endobronchial lung volume reduction. However, now it can be used for lung volume, in the persistent air leak. These are endobronchial wall Zephyr. It's a nitinol framework supporting silicon duct bill. This is intrabronchial wall. It has 5 anchors to hold to reduce the risk of migration, and it can be removed after 6 weeks. These are at advantage, however, these are associated with complication like pneumothorax, infective exacerbation, hemoptysis, wall displacement, and wall expectorations. The surgical, those candidate who has persistent air leak, like previous talk, 2 weeks or 3 weeks, we consider for surgical exploration, re-exploration. In a NET trial, the 22 patient out of 466 who experienced air leak underwent re-operation. The technique, these are, we have seen how it's difficult to manage the air leak. But as Pallavi said, the prevention start before the surgery. So here also the technique to reduce are start with pre-operatively, intra-op and post-op. Pre-operative, yes, I'll finish in 2 minutes. Study the CT scan, identify margin, and decreases the dose of inhaled steroids. The intra-op strategies are avoid high ventilatory pressure intra-op, careful breakdown of adhesions and release of inferior pulmonary ligament, suturing of the air leak. You can use water pour and locate the air and confirm and seal those air leak. Buttress the staple line with pericardium other material, glues, decortication if required, enforcements of the stumps, and if there is small leak, you can use a fibrin or synthetic sealant. As discussed by previous talk, pleural tending and pneumoperitoneum is used. The surgical sealant here again the same. The staple line buttress, believe that many air leak occurs along the staple line or adjacent tissue. So buttressing reduces the incidence and duration of air leak. The material used during buttressing is bovine pericardium, polytetrafluoroethylene, parietal pleura, polydeoxane ribbon. However, non-absorbable material causes granulomatous inflammation and bacterial colonization, and metalloptosis is the complication. This is a stapler which has a buttressing material incorporated with it. NET trial used bovine pericardium in all cases with fibrin glue and polytetrafluorine in one case. But it reduces the buttressing reduces both incidence and duration of air leak. There are variety of sealant already used during to reduce the air leak. Other technique like apical pleural tenting and pneumoperitoneum as already discussed. The post-op techniques to reduce the air leak include avoid mechanical ventilation post-operatively, that is on-table extubation, and avoid routine chest drain if possible. But in case of LVRS, we have to keep the drain but not to connect it to the digital suction device. This is the NET trial, which emphasizes on management of the lung volume reduction surgery. So the other option apart from the LVRS is the lung transplant. However, the scarcity of organ make it it is not so much available freely. So LVRS is the only option. Thank you.
Nikhil, that's quite an extensive coverage of LVRS as well as its complications. You went beyond your scope and well coverage. If you ask me, persistent post-operative air leak is a nightmare for any thoracic surgeons.
Yes.
The best is to have patience and do a meticulous adhesiolysis and avoid air leaks at the time of surgery. The best place to avoid is during surgery. And if there are air leaks at the time of surgery, at the end of surgery, you have to do whatever has to be done. Sometimes you get surprise air leaks post-operatively that you are not expecting on table. That's where sometimes you have to look at your chest tube. While transporting the patient, they would have applied a clamp and making a hole in the chest tube. Pseudo air leaks, that needs to be ruled out. You may not have seen, that's why you are not stressing that importance.
Yes.
And my preference for a persistent post-operative air leak is autologous blood fluorodesis. Using of any other chemical is likely that chemical will go into the alveoli, triggering a chemical pneumonitis and maybe disastrous for the patient. So my personal preference is autologous blood, and it has given me good results. Any comment?
My personal perspective is autologous. Yeah,
activate that mic bar. Yeah, we can hear back.
Yeah. Even my perspective as many patients who have post-operative air leak, especially after VATS cases, where you do lobectomies or sometimes segmentectomies. you get the blood air leaks more than 7 to 14 days, then I do autologous blood transfusion. 100 ml of non-heparinized blood you should put through the ICD and keep the ICD at the higher level. Do not connect the underwater sealed bag. Use a flutter bag with this and keep it at a higher level for 1 to 2 hours. Let the blood coagulate and then you can lower it.
I didn't want to go into details. When you use autologous blood fluorodesis in a patient already having air leaks, say you are doing fluorodesis in a patient with pleural effusion, malignant pleural effusion, you instill either Talc or slurry or chemical agent and keep the ICD clamped for 2 hours, asking the patient to change the position for the chemical to distribute. But if the patient is already having air leaks, you cannot clamp the chest tube. What you do is put the chest tube over a drip stand so that the air can come out, but the medicine blood that you have put in will remain in the pleural cavity. Never clamp it, and it's connected to underwater seal like before. And then 2-3 hours later, you release it. You let the blood come out, but nothing. It works beautifully. I'm really impressed and I use it without hesitation.
Very good, Dr. Nikhil, you have covered extensively. And I think as we have to talk in the context of lung volume reduction surgery and what is the air leak, because that is the worldwide experience. The air leak incidence is higher after, because the lungs are fragile. They are more likely to give to, even if you use the best stapler technique, there's greater incidence of air leak. About the point of, though it is a worldwide consensus, yesterday also it was talked that we don't have to use suction following this. But somehow I'm feeling as such after thoracic surgery per se, if we keep a reasonable, correct amount of suction and keep the lung fully expanded, then all air leak settles much faster. That is something which can be an area in which some study can also be done. That's a possibility. But most of it have come down. And I think this is one area where technology has helped us, definitely.
Yes.
Greater use of staplers as well as digital portable suction devices. These two things are a great intervention, because I have been a thoracic surgeon in the era of 1992, 2000, 2002, 2010. And following 2010 when I've used it.
Yeah.
So there's been great difference, market difference, because even physiotherapy, the amount of effort I used to spend on physiotherapy before 2010 has almost decreased. I don't even bother still, because lung is in an expanded state by suction. It is okay.
The other trick that I use in a patient with persistent air leak, him being in the ward and you seeing him every day and trying to explain, just send him home with the tube.
Yes. Yes, I connect to the flutter wall and
bar gains some time, and believe me, it works wonders and it stops. Thank you. Thank you, Nikhil.
Thank you, sir.
Our last speaker for this session is my colleague Vijay from Bangalore. He is going to speak about post-pneumonectomy complications. Can we bring the PPT, please?
From the 2 words of, say, watchful expectancy and masterly inactivity, we have to coin a new word of observation for some time.
Send them home.
Send them home.
Believe me, it gives you peace of mind, and patients will also benefit. Every 3-4 days.
Very much patient. Thoracic surgeons have to have a lot of patience.
Lot of patience and impatience. Impatience both at the time of tear of the pulmonary artery.
Unlike the institution-based practice like Diwan or Pallavi, where patients can be for 15 days, 20 days, it doesn't cost matters. But in a private practice setting like me or Vijay, where every day meter keeps running and you are bombarded. So it is.
Even in SMS medical college, we send the patient with the tube home.
Because you have 4,000 patients to admit.
And they are used to, by 3-4 days in the post-operative ward, they are used to it, and it helps, immensely helps. Thank you, Vijay.
Yes,
Continue.
thank you, sir. At the outset, I would like to thank the organizing team to give me an opportunity like this, and greetings from Department of Thoracic Surgery at Narayan Ruduralaya, to the chairpersons and my dear colleagues. My topic allotted is post-pneumonectomy complications. We have already seen much has already been talking about the same in the last 2 days. I'd like to try to stick to this one and some highlighting complications after pneumonectomy. Next slide. Next slide. Slide is not moving. Okay.
pneumonectomy is considered one of the most morbid surgery in the thoracic surgical practice. Best is to avoid it. Probably all the surgeons would try to avoid it. But in malignancy conditions, probably recently with advent of good adjuvant chemo and radiation, we are able to avoid pneumonectomy in most of the conditions, and in many of the situations by trying to do a sleeve resection, try to conserve the lung parenchyma as much as possible. But with rampant TB and particularly in a country like us, we are still ending up with destroyed lungs necessitating pneumonectomies. It's not the complexity of the procedure, it is the number and the severity of complications which we are dreaded about. Both early and delayed, sometimes even decades later, complications can happen after a pneumonectomy. So considering all these things, it's even labeled as a disease by itself rather than just a procedure in thoracic surgery. Complications can be based on timeline situations like early, intermediate, and late, and systemized complications like pulmonary, pleural space, cardiovascular, and other uncommon complications. Pulmonary complications major include intraoperative spillage to contralateral lung, as mentioned earlier, particularly in a destroyed lung with bronchiectasis, pulmonary edema postoperative, chest infections and pneumonia in the postoperative settings. After a pneumonectomy, in a single lung patient develops a pneumonia, we can know the catastrophic situation we can face, and rarely post-pneumonectomy syndrome. Pleural space complications, immediate postoperative, contralateral pneumothorax if opposite pleura gets opened up either during the procedure inadvertently, hemothorax, bleeding, chylothorax, we have spoken about yesterday, post-pneumonectomy empyema, one of the most dreaded complication, bronchopleural fistula, and rarely a esophagopleural fistula also. Cardiovascular complications commonly include arrhythmias, mediastinal rotations, cardiac herniations, rarely if there is a pericardial defect or something, myocardial infarction and cardiac failures in a borderline patients, and pulmonary embolism. Other complications include pneumopericardium occasionally, pericardial tamponade if there is a small opening in the pericardium, pericarditis sometimes, scoliosis especially in younger patients after a pneumonectomy, vocal cord palsy in left-sided resections because of dense adhesions, post-pneumonectomy paralysis in a left lower mobilization where it can rarely involve a spinal vessel for the anterior spinal artery. Coming to pulmonary edema, has got incidence of roughly around 2 to 4%, more frequent with right pneumonectomy. The pathogenesis is multifactorial, probably because of the reduction in the pulmonary vascular bed after a pneumonectomy. BOS has a variant of an ERDS with drastic post-operative courses. The management would be best supportive measures, including ventilation and this one. But despite all the efforts, it still has got a high mortality. Post-pneumonectomy syndrome can occur anywhere from 6 months to even decades later also, usually seen after a right pneumonectomy. It usually happens because of extensive compression of the lower trachea and the main bronchus because of the mediastinal shifting and rotation due to the hyperinflation of the opposite lung. Presents with progressive dyspnea, cough, inspiratory stridor, recurrent pneumonia, and occasionally dysphagia also. We need to rule out worsening chronic obstructive disease, bronchiectasis in the remaining lung, and sometimes in a malignancy case, a recurrence of CA. A pictorial representation showing the pathogenesis of post pneumonectomy syndrome, where we can observe the compression of the left main bronchus anteriorly from the LPA and posteriorly between the vertebra and the descending thoracic aorta, which is not the case in a left-sided pneumonectomy where right main bronchus can still maintain its patency. Management would, if it is bothersome and persistent, this one would require a surgical repositioning of the mediastinum and filling up of this the pleural space with a non-absorbable material, either with a fixed volume or adjustable prosthesis material in either an intra or extra pleural space. Sometimes, if there in a long-standing case, might end up with a tracheobronchiomalacia, which might require stenting to maintain the patency of the statement. A scan, a representative picture showing a manifestation of a post pneumonectomy syndrome with compression of the main bronchus leading to stridor and repositioned with the expandable processes to maintain the position of the mediastinum. It was described by Rakovich in one of the MMCTS article. Coming to post pneumonectomy empyema, which we have spoken for last 2 days extensively, can complicate up to 5% of cases of pneumonectomy cases. Can present either early or late. Early empyemas usually can be associated with accompanied by BPFs also. Late cases typically happen after 3 to 6 months, but can happen even up to a decade or even 2 decades later also. Typically, infection gains entry through the hematogenous route, and diagnosis based on the radiological, and if required, if there is any significant doubt, can even contemplate sampling of the pleural fluid also. Management include drainage and appropriate antibiotics in the immediate period. But some patients can persist or recover, necessitating continuous drainage in the form of either an Allozier window or a Claggett's window, which offer better drainage and control of sepsis. And in old and debilitated patients, sometimes can be left alone so that they can continue to manage with like that. Few of the pics from our earlier cases represented showing the evolution of the window thoracostomy. Slowly it matures. If you make a bigger window in the earlier phase, slowly it contracts and leads to, if you make a smaller window in the beginning itself, it might close off spontaneously, requiring probably reopening or laying open at a later stage. So especially in a post pneumonectomy space, the space might take some time to sterilize itself also. Bronchopleural fistula, one of the dreaded complications after a pneumonectomy, happens in the range of 2 to 4% with present all the advancements in technologies. Has got higher morbidity and mortality risk, as already explained. Higher chances after a right pneumonectomy with a long stump, or active TB infections or infective pathologies. Elderly patients, diabetics, and in malignancy patients, either a positive margin tumor at the bronchial staple line, or post chemo and radiation therapy. And prolonged post-operative mechanical ventilation is a known risk factor for that. Presentation include fever, cough with copious sputum, particularly independent position, hoarseness of voice. Sometimes if there is a big BPF, the whole tidal volume might be lost through the BPF itself, and they will have even weakening of voice also, and sometimes with respiratory distress if there is contamination of the opposite lung, and prolonged air leak in the chest drain. And detection, usually chest X-ray would show either a new air fluid level or reduction in the previous present air fluid levels, and sometimes even multiple air fluid level also. One of the follow-up patients X-ray who presented with delayed BPF shows a reduction in the previous existing air fluid level in a newer chest X-ray, denoting a development of a bronchopleural fistula. Treatment to include, the important thing is to protect the remaining opposite lung. So to keep the disease site down and drain the pleural space appropriately with chest tubes and systemic antibiotics. And probably after sterilization of size, either with chest tube or a window, this one. If it's an early BPF, probably attempt a surgical repair of the bronchopleural fistula in the form of re-exploration and primary repair, along with cover of tissue flaps as mentioned earlier. But in a delayed BPFs, initial management would remain the same, to sterilize the cavity with drainage, and followed by either a Claggett's or a Allozier window with appropriate antibiotics. And more important, we need to correct the nutritional deficiencies also. Primary repair would be of questionable value because there is contamination in the cavity, fibrosis, and doubtful vascularity. And sometimes the previous thoracotomy would have divided much of the musculature of the chest wall itself. So impending high failure rate post attempted primary repairs also. So to counteract that, different approaches have been described upon to go through different areas. So one of this one is transternal approach, where you can approach through a fresh tissue planes, native tissue planes, away from the contaminated cavity. Even though it looks appropriate, but not so easy to work in a very narrow space between major vessels. But one of our earlier case, along with Dr. Sri Krishna, which was attempted, shows this case where a left main BPF was repaired through a transternal approach. You can see to the right of the screen, the looped SVC. The left is the ascending aorta, and the lower one with the tape is the right main pulmonary artery, which exposes the left main bronchus. The next picture shows the divided stump, which was even covered with a glue, and later on with a pedicled omental flap also. Another approach, much more minimally invasive approach described to handle this situation, was described by Carvadello in 1996 itself. The Vambla approach to divide the left main stump, even more narrow space and more difficulty to handle through that, and especially surrounding fibrosis near the main bronchus area. But many case reports have been reported with video assisted mediastinal division of the left main bronchus if there is a long stump to this one. And particularly placing of stapler is also very difficult with this approach, but things have been done and still continue to do it also. In situation like this, where there is a significant mid-directional shifting and rotation, if there is a BPF in this situation, either both transternal approach and even for that matter, video assisted approach also becomes a risky thing. So when we were trying to go through the literature search, Klepetko group from Vienna have described a right-sided thoracotomy approach for management of left-sided main bronchial stem problems. They have managed close to, this was back in 2011, reported in European Journal of Cardiothoracic Surgery, where they have managed 5 cases of post-left resections BPF, including main stump, which was handled with a carinal resection, sleeve carinal resection also. One of the representative pictures showing right thoracotomy approach, which gives much easier approach to the carina and the main bronchi. And even carinal resections have been described through right thoracotomy approach. And they handled even bronchopleural fistulas, BPFs, and even carinal sleeve resections also. So an approach to think of for this kind of a difficult situations in post-pneumonectomy patients. And last but not the least, the good old thoracoplasty. Dr. Divan sir is there, who is main this one along with Dr. Rajan Santosham. As saying goes, if Muhammad doesn't go to mountain, bring the mountain to the Muhammad to obliterate the residual pleural cavity, for particularly for a post-pneumonectomy empty pleural space infections. One of the post representative picture of a post-pneumonic right side pneumonectomy patient underwent with thoracoplasty correction of the residual space empyema in a post-pneumonectomy. This one. So even though it's best to avoid complications, but complex surgeries will have inbuilt complex complications, and complications are part of surgeon's career. We should have enough skills in our armamentarium to handle those complications and to share each other's problems and to learn from others' learnings to improve our patients' outcomes and problems. Thank you.
Vijay, that's quite an extensive cover of a complicated topic. Rather. I think no one patient or you can prescribe no one procedure for post-pneumonectomy to do this. It's impossible. Each patient has to be evaluated, bronchoscopy, CT scan, and then talk to your colleagues with a bigger experience and integrate his thoughts. And then you come up with a plan to manage that given patient.
Particular patient.
Otherwise, it's not possible. If you can work with another equal-minded surgeon on that patient, that will be the best. Thank you for covering that extensive topic.
See, it gives me an opportunity to share some of the complications, rare ones also. See, in my career, if while doing pneumonectomy, if you have to take an intrapericardial control of vessels, and if you leave the pericardium open, I actually ended up doing it once. And second, a cardiac herniation through that pericardial opening can kill the patient. So always close the pericardium with interrupted suture and with a little window. You can't close it continuously because otherwise it will cause pericardial tamponade itself. So you have to do that, number one. Number two, I mentioned that after pneumonectomy, your patient is not doing well. You are not able to see not much bleeding, not much fistula, and yet patient is having problem. Consider pneumothorax on the other side. During some kind of anesthesia problem might have caused pneumothorax on the other side. That can get missed, and you may end up losing a situation where you could easily save a patient and getting the patient lost. Thirdly, about this bronchopleural fistula and thoracoplasty, I think we have tried the endoscopic glue technique, sending patients for transternal approach and all these heroic surgeries, etc. At the end of it, I have found the conventional approach of good drainage, followed by window thoracoplasty later on, as and when it is suitable, as the best approach. And the kind of cosmesis and the difficult skeletal malformation, they also do not occur if you do them very correct. Because that kind of shifting of chest, etc., has already taken place. If you've done a pneumonectomy and patient has waited, you are just completing the procedure which nature is intending to do anyway. So the only thing is that it has to be added very well with physiotherapy, pain control, preparing the patient for those things, and giving him a good quality of life. Our aim should not be to give a bad quality of life. Another area which I want it to be explored is because right-sided pneumonectomy fistula rate is higher in all of our control. We have started using the stapler with a 3 rows. Does it decrease the incidence or not decrease the incidence? That is for you guys to explore, work, and collect data.
Now we have in mind, sir, because initially we used to, in open cases, we used to use that 2-line, that open staplers, but it's all in single length And many times different patients can have different thickness, and some old patients can have calcified cartilages also. So might not give complete appropriate closing of that, because even after lobectomies, we had 2 fistulas with these open staplers. So after that, we started using this tri-staplers. Slowly, we are noticing a little lesser post-operative BPFs.
All endo staplers come with 3 rows of
3 rows,
staples.
and nowadays
That's
with
the
different
best.
heights of staples.
Yeah.
So that probably might also give better closure of incidence of hair leaks also.
Yes, sir. Please, sir. Give them a mic, please.
Yes. Thank you, sir.
Very dreaded complication, post-nephrectomy, empyema, etc. I just tell my experience. In one of my patient, I did pneumonectomy for post-tubercular cases, hemoptysis, etc. And patient did well, and after 2 years, he came to me with the chronic cough. I am having cough for the last 2-3 months. I investigated, but nothing is found. And lastly, I did bronchoscopy. So in that, there was a rent in the stump communicating with the pleural cavity. There was no pus, nothing. It was a small pocket. But his persistent cough was persistent. So I couldn't offer anything to him. He is still like that. But I just take the opinion of the house, how such situations should be.
That is bronchopleural fistula, sir.
But it was not.
Do CT scan. CT scan will delineate some space. If some space is still present in the CT scan, then we can very carefully plan thoracoplasty.
Patient came back after 2-3 years.
Yes,
2-3 years.
It can. I have done thoracoplasty after 15 years of a pneumonectomy done elsewhere. It is very challenging. But
To my mind, that is this fistula is a fresh one, not the.
It's an old fistula also, because some of the patients with bronchopleural fistula we have managed without anything also. They remain reasonably well because the chest wall contracts, very little space is there.
Yeah.
But you have to identify how much space is there. A CT scan is the right investigation.
You
And
want to say that
sometimes
this is a fistula from beginning?
From maybe 1 or 2 months after surgery. We cannot never say it. It can develop.
If the symptoms are troublesome, only then we need to think of what to be done. If the patient is happy, reasonable with his symptoms, we know why. But if he is okay, he can manage, then stay out of it. Don't do anything.
It's a very, very careful decision, because sometimes ending up doing this procedure may worsen the patient and may actually end up killing the patient, an alive patient.
One thing more I want to share, that I went to Kuwait sometime before.
Another thing I used to mention, sometimes in these situations, while doing bronchoscopy, one can find bronchoscopy sutures or staplers lying loose, and they have to be removed for removing the cuff. Sometimes that can also be present.
There was a thoracic surgeon, Abdul Qadir.
Yes.
Adil Khadar, like that.
Yes, I know him. I have met him. Yes.
He was very, he used to use Prolene suture while closing the stump.
Yes.
He didn't use staplers. Very, the moment you take the, give him, why can't we use the stapler? No stapler, just sutures. So what is his ideology behind?
You see, Blitz from South Africa. For pneumonectomy, the published experience, the maximum one has been from Blitz by South Africa 2002. He is a great proponent of only hand-sewn techniques. He says mechanical staplers are inferior than hand-sewn techniques. But that's an older surgeon. Now the stapler technology has become so much better.
3 layers of stapler.
Staplers and other things. We definitely feel the staplers provide a better this thing.
Right.
It looks at the beginning when the staplers were introduced, it's an industry driven, etc. But personally, I prefer to close bronchial stumps or separate the fissures with the use of endostaplers, and I have good results. And I go to sleep well at night if I have used the staplers.
And I think the money spent on staplers
is worth it.
Yeah.
It's a money which gives return in terms
Yes,
of human
yes.
suffering being reduced. So it is a money which is well spent and it has to be used. And sometimes if you have to see bronchoscopy, sutures may be present, loose sutures.
Loose suture, yes, sir.
Many-
Post lobectomies,
post-
sleeve resections, probably
Sleeve
they have
resection,
higher
loose sutures
chance
and
of
they
this
can be
sutures.
hanging, especially when silk was used. And cardiac surgeons are very fond of using Prolene because they use Prolene in other situations. Those who are cardiovascular thoracic surgeons, they use Prolene. Most of those who have been trained only for thoracic will use either an absorbable suture like Polydixon, Vicryl, or a stapler.
He was not a cardiac surgeon. He was purely thoracic.
Okay.
But Ethibond was also used earlier.
But you see, pneumonectomy is an experience. It can keep. Another issue I wish to tell was that if there's a post-pneumonectomy space, there has been a paper in which people have put silicone implants to bring back the mediastinum. So that is also some cases we can start working on.
the how to close the bronchial stump, whether sutures or stapler, used to be a debate in every meeting, say 10, 15 years back. Now it is more and more procedures are done. Almost 99% of the procedures are done thoracoscopically, and there is no way you can do it without use of staplers. So that debate whether to use or not is gone. Thank you very much, Vijay. Thank you, organizers. Thank you very much for the Pink City. We enjoyed. I enjoyed. Thank you.
Thank you, sir.
And the close thoracic session. Great.
Wait for a moment to come for Dr. Nikhil. Not give it.
And good use of time when 10 to 11 session was cancelled because PGs have to go to Alia for the quiz. That's when I called you. Why can't we finish it? Because if they start from 11 to 12 and then we have to wait till 1 o'clock. No.
What was the good?
Make this transgender, it is a good. The
Space not sterilized. The window was there. That given patient, there was a long left bronchial stump. So you could use that. But if you think of using Ramla to close the left main bronchus, long stump, and Ramla and what is a stapler, you have to take endobronchial endostapler. You can't use the open stapler. And if you take the endostapler, if this is the bronchial stump, it has to go beyond. And beyond is the pulmonary artery. And you cannot see that tip, and if you uproot the pulmonary, I am literally scared when you show that.
Probably to share our experience before with Dr. Arvind. We had done at PP Just Institute, one of the post with video assisted meditation of the main stuff for the network for the so one case.
I could never get someone courage. What if this distal and
now we do the bronchus. It's a very difficult and a challenging procedure. Yes. So we have that snake retractor where you can go around the bronchus and come, put a thread over there, loop it, and with the loop you can pull the bronchus down into the stapler and fight through the stapler. Your heart will be getting faster than
I contemplated even 2 or 3 cases, but never someone courage. Similarly,
now it has become video assisted, so that that way the vision is there.
That 5-6 years I was associated with sanatorium with Yashinder Buki.
Yeah.
We have done quite a good number of post-pneumonectomies. Kind of those who were pending for long years we have done. Thoracoplasty or a muscle flap. Oh, works beautiful.
That is the ultimate way. You don't have to think much about it. You do it.
It's a known devil, known angel. Procedure is not to you.
Muscle transposition post-pneumotic stage as we talk about in Gupta Jayapur, I have never found people have done muscle transfer, even
In fact, those BPFs, previous surgery was done thoracotomy. So I used to argue that the muscles are already cut, how do you get? But used to mobilize serratus anterior, not the pectoral muscle, serratus anterior. There was enough bulk of the muscle to go through the remaining bronchial stump and buttress it. That's beautiful.
and this one is just left alone.
Minimal symptoms, you should leave them all.
We have around post-pneumotic 10 years. We have a lot of BPF now.
If small BPF, put a view there.
Do nothing.
But a patient now windows sterilized cavity, everything is fine. But as main this one is not able to see.
Actually,
everything is fine. He's fine. He's doing well.
I don't know why don't you stand on the window like
Window should be.
Colostomy bag or something should be able to.
Window should be 3 meters maximum.
Not 4, 5.
Then it is not possible.
That will close. That will close.
It did not close. We did surface after
Definitely patients will lot of us.
What people evacuated single result.
For your window patients, typically for those this is as Japan or somewhere. They just said only one. If there is crowding or there is no crowding, leave it like that. Apply a wound protector. Leave it up. It will keep your wound patient also nice and clean wound. No cutting, no nothing. Good dressing. Absolutely. We have done in 2 cases. And I have attempted a second stage decortication after a small window. That patient has recovered well after the window procedure. Utility wound and wound protector. Okay, sir. All right. Yeah, for that.
Yes.
Madam. You have to make it.
Dr. Nikhil.
Vijay, come and join us. Madam, you also come. Motion. Yeah. Thank you. Thank you. Thank you very much. Nice. Yes.
Yeah.
Okay, you can go to the next speaker.
Yeah, we can, since the topics are interrelated, we can ask questions whenever we want. The next speaker is Dr. Shoaib Padaria, who is Director of Vascular Sciences at the Jaslok Hospital, Mumbai, and the Vice President of the International Union of Angiology. So
Right,
can we please have his pre-recorded video started?
Yeah. Start.
Dr. Shoaib.
Hello, friends. I'm Dr. Shoaib Padaria from Mumbai. And my topic of presentation today is interventional therapy to treat obstruction of iliac and femoral. So
We can't see his video.
Femoral vein obstruction is most symptomatic for unexplained irregularity.
Please share his video.
As we all know, deep inflammation is a common condition. Leading as part of the birth and these conditions over more people rely on than breast cancer and cancer. So hydrofemoral vein thrombosis accounts for almost 25% of all neural.
Dr. Sisodia, the video is not being shared.
Anatomic predisposition to venous stasis. The most common amongst these is the compression of the left iliac vein between the and a vertebral body, also called the May-Thurner syndrome.
Hello, friends. The most common amongst these is the compression of the left iliac vein between the right iliac artery and the vertebral body, also called the May-Thurner syndrome. In addition to anatomic status, the majority of patients with iliocerebral disease have at least one additional risk factor for venous thrombosis. This could be a post-operation state, prolonged mobility, malignancy, pregnancy, and inherited hypercoagulation. Why is it important to treat the first important is total obstruction of the hydrofemoral segment and the thorax, leading to a gangrenous legs or like this. Now, how do we treat this acute iliocerebral disease? The question may be asked is routine anticoagulation effective in clearing the thrombus in proximity to the vein? Almost 30 studies have compared anticoagulation and we can see from this chart here, in this complete lysis of the clock, approximately only 4% of patients. There is a lysis drug such as urokinase, tetrakinase, or alkylates or reticulates. A complete lysis is still less than 30%. So what are the methods of removal of this? Of course, you can do operative mechanism, procedure, or you can do one of the endovascular procedures. Among the endovascular procedures is catheter thrombectomy, ultrasound accelerated thrombectomy, or various cross-vigilantly mechanical thrombectomy conditions such as angioedema device or a stethoscope. The most common among these is catheter thrombectomy, which is performed in the cath lab of the USC. In this, we insert a multi-hole catheter for the investigation of thrombus in the iliopsoas vein. We give a bolus of the thrombolytic agent for the infusion for about 12 to 24 hours. After partial lysis of the clot can then be mechanically aspirated from the vein and large vein cavity. And if any residual cirrhosis remains, then balloon dilation and occasional stenting is performed. Now, if this thrombolytic therapy has been financially beneficial, long-term studies have shown that over a period of 5 years, there is a definite benefit. For example, with lysis at 5 years, only 9% of completely died at 5 years. But without lysis, almost 77% of people died. How do we do this catheter-directed thrombolysis? Here is a case study of a 45-year-old patient who presented with severe swelling in the right leg of his thigh. With severe, intolerable, unbearable pain. The history was a 2 days with a low response to normal flow of and even Dr. Armstrong, even after 2 days, approved total solution for the right side of his identity. Now we see from this case how we do it. We see a catheter and a wire inserted constantly in the catheter vein, and you see the wire going up in this catheter vein and then push up the back to a thrombotic vein segment all the way through the iliac vein into the illusion. A venogram, which is performed, shows that the entire vein, right from the completed vein upwards, is full of blood. Over the wire, the multi-hole catheter is now put in, infusion of RTP is given for 12 hours, and once that is done, the clot is coupled, the aspiration of the clot is done, followed by balloon dilation of various segments. Once this is done, and the venogram is subsequently performed, you see that recalibration vein is seen. This is the distal central vein. This is the intraocular vein. You see from there that even after thrombolysis and balloon dilation, some degree of cirrhosis is further balloon dilation performed with a larger damaged balloon. You see from there that the vein is still not fully open. This is a stent, excellent flow in optic flowing items, and resulting in good action.
What happened?
We are not seeing the video or the audio. Yes, we got it. Yeah.
Good evening, ladies and gentlemen. I bring greetings from Bristol Medical College, Vellore. My topic for today is recent advances.
Can you just pause the video? Yeah. Dr. Yadav, have we finished with Dr. Pataria's talk?
Yeah.
I think there were some few minutes left. I think.
Yeah.
The last few slides. Yeah.
So Dr. Pataria is with us, and if there are any questions or welcome, Dr. Pataria. Dr. Pataria, as I said, is the Director of Vascular Sciences at the Sloke, Mumbai.
Yeah.
And he spoke on venous interventions.
Dr. Pataria, what you choose the urokinase or A TPA or as a so what we call streptokinase? What you choose?
Yeah, so originally 25 years ago when I started doing this, we used to use streptokinase. We then went to urokinase, but currently we use either retiplase or altiplase. And the reason for that is the allergic reactions to these drugs are almost non-existent. And secondly, the mechanism of action is much faster using retiplase or altiplase.
And what rate you recommend? Rate of
So yeah, so initially what we do is we give a bolus of around 5 to 10 milligrams into the thrombus, dispersing into the thrombus with a catheter. And then usually we give 1 milligram per hour diluted in about 50 to 100 cc's of saline. The idea
Yeah.
is that we can give a good pressure with the saline into the thrombus, causing maceration of the thrombus and thrombolysis at the same time.
Are you guided by some investigations
Yes, you're right. So what we do is along with this, we also give from the side arm of the sheath heparin at 1000 units per hour. And we do a PTT every 6 hours.
a PTT?
Yes.
Right. And did you encounter any more incidents of thromboembolism by this? Because a bigger clots are dislodged, then they go to the pulmonary circulation and
So that is a definitely potential complication which can occur with this procedure. However, you know that even if tiny clots do go up into the pulmonary circulation, the treatment for that is just the same by thrombolysis. So if you do a CT scan immediately, let us say within 24 hours of starting the initial procedure, you will see some clots in the pulmonary circulation. But if you
Right.
repeat this CT scan at 7 days, you will see that these clots have totally dissolved because of the thrombolytic drug that you are giving.
right, right.
Dr. Yadav, if I may add over there, that very, very rarely, what Dr. Shoaib has said is correct, but very rarely, we sometimes, if the thrombus load is very high, or if there is a clot also in the IVC, we might put in a IVC retrievable filter also. And I
Right.
believe Dr. Shoaib has one of the largest experience of this.
So you need to put it in advance
Yes,
before
yes.
starting thrombolysis.
That's right. But very, very rarely. But yes, we have to keep it with us. That's true.
Okay. Thank you. Can go to the next presentation.
Next is Dr. Malay. I think because we started a bit early, so he may not be here. He'll join us shortly. We can move on to the fourth talk, which is recent advances in venous ulcer therapy by Dr. Deepak Selvaraj, who is professor of vascular surgery and who is president of our venous association. He is in the CMC Vellore. So if somebody can please play his pre-recorded video. Thank you. The fourth talk, Dr. Deepak.
Good evening, ladies and gentlemen. I bring greetings from Christian Medical College, Vellore. My topic for today is recent advances in management of the venous ulcers. I am the head of the Department of Vascular Surgery at Christian Medical College, Vellore, and also the president of the Venous Association of India. I would like to acknowledge my training with Dr. Sheshadri Raju before I start this talk. He is an alumnus of Christian Medical College, Vellore, and has been a very important part in our training here. I have no disclosures. The venous ulcer is an open skin lesion of the leg or foot that occurs in an area affected by venous hypertension. So, what causes venous hypertension? It is because of impaired valve function. The normal valves allow unidirectional flow of blood towards the heart, whereas if the valves are damaged, the flow becomes multidirectional and tortuous. And this can be due to thrombosis, acute deep vein thrombosis, or impaired muscle function. The heart acts like a pump to push the blood out. So persistent elevated ambulatory venous pressures can be because of valvular incompetence, which may be primarily secondary. Good evening, ladies and gentlemen. I bring greetings from Christian Medical College, Vellore. Because of him.
Pad valve function. The normal valves allow unidirectional flow of blood towards the heart, whereas if the valves are damaged, then the flow becomes multidirectional and tortuous. And this can be due to thrombosis, acute deep vein thrombosis, or impaired muscle function. The calf pump acts like a pump to push the blood up. So persistent elevated ambulatory venous pressures can be because of valvular incompetence, which may be primary, secondary, or congenital, or loss of reflex construction of the precapillary arterioles. This is a very important graph that I would like to show all of you. And it talks about the hemodynamics of chronic venous insufficiency. The normal ambulatory venous pressures are around 80 millimeters of mercury as you stand. But when you tiptoe, the pressure drops because the calf pumps and pushes all the blood upwards. And then it comes to around 30 millimeters mercury and then slowly starts going back up to the normal within 10 seconds or 30 seconds. So this is the normal ambulatory venous pressure graph or plethysmograph. Now what happens if the saphenofemoral valves are incompetent? The main axillary valves at the saphenofemoral junction is incompetent. But if the calf muscles, the perforator veins are normal, then the blood comes back into the calf pump and the normal calf pump can push up the blood again. So the ambulatory venous pressure can still drop by around 40 to 70% in spite of the reflex. But if the calf perforators are incompetent, then the reduction and drop in ambulatory venous pressure is only around 10 to 50%. It becomes more aggravated if there is a proximal venous obstruction because of deep vein thrombosis, chronic deep vein thrombosis, or changes due to acute deep vein thrombosis, where the pressures will drop by around 10% only, resulting in chronic ambulatory persistent venous hypertension. And that causes localized changes at the skin level. And there are many theories of what happens at the microvascular level. I'm not going into that. That results in a very bad venous ulcer around the gator area with sloping edges and slough and granulation tissue. The ulcer is painless. And this is how it looks. So before you start treatment of these patients, you need to assess the wound ulcer thoroughly and look at the margins, make sure your diagnosis is because of stasis, and also look at, most importantly, a vascular assessment of the blood flow. So look for absence of pulses. And most important thing other than this is to do a duplex ultrasound. The duplex ultrasound actually looks at reflex at the saphenofemoral junction or along the saphenous vein or the deep venous reflex. Also look for the pulses as well and measure the ankle brachial pressure index. So this is how we treat these venous ulcers, but the common aim is to reduce the ambulatory venous pressures at the ankle, and there are several modalities available, but the most important thing is compression therapy, and evidence is very, very in favorable of compression therapy. Multi-layer bandaging systems are much better than two-layer bandaging systems. The pressure exerted around 30 to 40 millimeters of mercury, and hence they compress the calf pump and reduce the venous pressures. So what evidence do we have in India? We looked at our own data, and this is the 4-layer dressing that we use. We're around 40 millimeters of mercury. It's available as well for, and then we do this in our outpatient clinic, either the vascular technicians or the doctors. We always check the ankle brachial pressure index before that. And we also wanted to look at the time to heal, the ulcer healing rates, and does it need any adjunct treatment as well, and also the compliance rate. And we looked at, we had specific inclusion and exclusion criteria. This was as early as 2015. And we looked at our results, time of healing, size of the ulcer, and the compliance rate as well. And if you look at how we classified these ulcers, they were large and small ulcers, and the time to heal were 12 weeks or more than 12 weeks. And the adjunct treatment done were also tabulated. We had around 217 patients, majority of them were male, and more of them were in the middle-age group with young families. And a majority of these ulcers were large, that is more than 3 centimeters, and most of them had actually healed with just compression therapy and adjunct healing. So complete were 127, partial healing were 40 at the end of 12 weeks, and many of the large ulcers had healed as well. A majority of the large ulcers actually took more time to heal than the small ulcers. And this is a very interesting slide where actually you see just with 4-layer dressing, the ulcers had healed, but many of them actually needed some adjunct treatment as well, which are the modern advances in the treatment of the superficial and deep vein and therapies. And several ablative techniques are available now, and there are thermal and non-thermal techniques that are available. In the thermal techniques, we have radiofrequency ablation as well as laser ablation, and modern studies have said that they are as good as open surgery. In fact, less painful, and quality of life is much better. We also use non-thermal techniques like glue and venous seal. We've done around 40 to 50 patients with cyanacrylate glue. Just go up to 5 centimeters away from the saphenofemoral junction and then inject the glue. It just sticks, the vessel just sticks to itself. This is another clever technique where we pass a probe and it has these octopus like phalanges which open and scratch the vein and goes into spasm, and we inject the foam as well at the same time. So thermal and non-thermal techniques are available, and we also have techniques to treat the perforator. We pass a probe into the perforator ring and inject foam sclerotherapy, or we can also do laser ablation or radiofrequency ablation of these perforators. We don't use the Chiva strategy, and this is another important thing that we've started doing. May-Turner syndrome, that the left common iliac vein is compressed by the right common iliac artery at multiple levels, and this causes ambulatory venous hypertension because of obstruction, like I showed you before. So we go in, we look at the inside of the vein, we look at sites of obstruction with an IVUS, and then look at, that's how a venogram looks like, multiple collaterals because of the splaying of the vein here, because of the construction, and then we angioplasty it with a large Atlas balloon and put in a Boston stent or a specific venous stents like Vinova or Optimus. And we've done, these are early statistics. We had done a lot of 40 to 50 patients in 2015 and 16, and it resulted in a lot of ulcer healing. But we also noticed that a lot of patients with post-thrombotic syndrome actually had recurrence. So now we're very guarded in our indications to use the venous stents. In conclusion, there are several modalities and advances that have been made in the management of venous ulcers, especially the ablative techniques have become less and less invasive for the superficial venous system. Iliac venous stenting has reduced the ambulatory venous pressures by improving the flow in the deep venous system as well. But however, the compression therapy still continues to be the mainstay of venous ulcer treatment, and multi-layer component dressing is much better than single-layer dressings. And these are some of our publications. I would like to thank you all for giving us an opportunity from Christian Medical College, Vellore. That's the fort and that's the Golden Temple. Thank you so much.
Thank you, Dr. Deepak. Are you online? Are you listening?
Yes, I'm online.
Yeah. Actually, to me, the cause of the venous ulcer is usually post-DVT syndrome, isn't it? Or can it occur in the simple varicose veins also?
Yes, post-DVT, post-thrombotic legs, that's what we call. That is one of the causes. There are several causes. All causes which leads to ambulatory venous hypertension can result in venous ulcers. So DVT is one of the causes.
But not the simple varicose veins.
Simple varicose veins can also cause, if you actually look at my slide on the ambulatory venous hypertension and the calf pump, simple varicose veins also result in increased because of axial reflex along the saphenofemoral junction, and the ambulatory venous pressure increase. The calf pump is not able to compensate as much as we would like it to do. So varicose veins, simple varicose veins can also lead to venous ulcers.
So for these chronic DVT, post-DVT syndrome, do you recommend this radiofrequency ablation or laser, etc., before treating the main obstructive lesion?
Well, we always treat the superficial venous system initially before treating the deep venous system. So superficial venous system, if there's a perforator venous incompetence or superficial incompetence at the saphenofemoral or the saphenopopliteal junction, we endoablate them with various techniques and then put them on compression therapy, which is 4-layer bandaging. And even if they don't, the ulcer doesn't heal, then we look at the deep venous system and where there's the iliac veins are obstructed, and then we go and recanalize the iliac veins.
So you don't even investigate for the obstructive lesion before ablating the
So we
superficial
are fairly,
femoral.
in a post-thrombotic leg, we are very fairly sure that the iliac veins are obstructed. So there is no question. Some people can do a CT venogram right at the beginning, but then we do it as the protocol at Vellore is we do it closer to the time of treatment.
One more question I want to ask you, like what investigation you have? We have done several CT venograms and doing it since years together, but we can't interpret any CT venogram in the context. This is a significant stenosis and this could need some stenting or some surgical bypass. What CT protocol you use for the venous for venography, CT venography?
Yeah, at Vellore, we don't use CT venogram regularly. We are more in favor of diagnostic venograms. And then diagnostic venograms, like the picture I showed you at different angles, give you a lot of answers. We do a mid-thigh puncture of the femoral vein and then pass a 6 French or Saint French catheter and do a diagnostic venogram. And then following the diagnostic venogram, we use the IVUS, the intravenous ultrasound. That kind of gives us great information about where the compression is in the May-Turner syndrome and where actually the pressures on the vein are. And then we are able to make a good judgment as to where we have to actually place the stent. So CT venogram is a very two-dimensional thing, and we really don't, like you said, doesn't give a great information. And in the venous side, it's it's not unlike the arterial system. Just a small occlusion can cause various degrees of venous hypertension downhill. So the whole concept of occlusion and obstruction are very different on the venous side compared to the arterial side.
Dr. Yadav, if I may slightly elaborate on your initial part of your question regarding venous ulcer and varicose vein. So venous ulcers are an integral part and an extreme form of varicose veins or chronic venous insufficiency. In fact, our classification, the C5 and C6 is actually varicose veins with ulcers. C5 is a healed ulcer and C6 is a active ulcer. Regarding the second part, which Dr. Deepak has very clearly said about IVUS, and this is a new sort of investigation which is invaluable if you want to detect the exact degree of stenosis, because as versus arterial stenosis, we don't depend on the gradients. IVUS is actually the gold standard now. And if Dr. Rahul Jindal is there, I would like him to give a short comment on IVUS. Dr. Rahul, are you there?
Yes, sir. I am there, sir.
Yes. Can we hear just a short comment on the utility of IVUS in venous stenosis?
Yes, sir. So basically, when we do a CT and MR venogram, and if there are standardized protocols, so you can interpret quite nicely, but you will not be able to see a lot of things on CT and venogram because the patient is in the lying down position. So the venous collapses, so vein collapse. So sometimes you're not able to visualize the narrowings, you will not be able to visualize the webs. So when we do a venography, a conventional venography, so that is you can imagine it's an AP plane, or you have to take a plane from the outside. You have to do two-dimensional venography. In that also, you will not be seeing when the contrast flows through that, you may miss a lot of narrowings, even in the conventional venography, and the webs you can miss up. So IVUS gives you a lot of information intraluminally. It also, even if the vein is collapsing, if you keep the probe there, so the vein collapse and distends with the inspiration and expiration, so which you can easily see. You can also see outside the wall of the IVUS, of the vein, surrounding like what is compressing the vein if there is an obstruction. So you can see extraluminally, you can see intraluminally very well, and you can also see the wall of the IVUS, of the vein. So if it's very fibrous tissue or if there is any web there, so that's why IVUS is very, very good investigations, if we compare, with any other investigation what we have available.
Thank you, Rahul.
Thank you.
Dr. Malay, are you ready and are you available?
I can go to the next talk.
Dr. Malay?
My screen.
Dr. Amla, can you share Dr. Malay's screen, or can he do it himself?
Okay, I'm sharing my screen. And
Dr. Malay Patel is one of the senior most vascular surgeons in Gujarat. He is a cardiovascular surgeon by training. Over to you, Dr. Malay. You can start. You can go ahead, Dr. Malay.
Sam, I am.
Yes, okay. We can see your slide.
Can you hear me?
Yes, very clear, very clear.
Yeah, slides are coming. You can speak, Dr.
We can see and hear.
Yeah.
Okay. Can you, did you hear my video on the talk? No.
No, you'll have to give it live. Yeah.
Okay, I'll give it live. Okay, no problems. Good day to you all heart menders, and today I will be talking about an overview of DOACs, that's direct oral anticoagulants. The authors are Malay Patel, Roy Varghese, and Manjusha, and I'm presenting this at the IACVTS VICON session of 2022. And I'm very glad that the IACVTS has collaborated with the VAI for this session. There are no conflict of interest and none to declare. The financial grant is nil. And so I heard that you finally tied the clock. And these two RBCs sure did. Coagulations. So this is the historical development of the anticoagulants. The unfractionated heparin came first, followed by the vitamin K antagonists, followed by the low molecular weight heparin, the direct thrombin inhibitors, the indirect 10A inhibitors, and now the oral direct thrombin inhibitors and factor 10A inhibitors. What are the direct oral anticoagulants? They were previously known as new oral anticoagulants, but since they are very new and indicated for VTE at that time, but now we also refer to them as target-specific oral anticoagulants, and this is a better name. And 4 agents inhibit factor 10A, apixaban, etrixaban, edoxaban, and rivaroxaban, and 1 inhibits thrombin, dabigatran, and they are licensed globally. So the ideal anticoagulant should have these points that we must look at. That dosing without the need for laboratory monitoring, titration by parenteral and preferably oral routes, availability of a safe antidote, and you can go through these points. The therapeutic indications, treatment and prevention of venous thromboembolism and atrial fibrillation, stroke prevention. The factor Xa inhibitors and thrombin inhibitors. Available human data in pregnancy are limited to case reports and pharmacovigilance analysis, and DOACs are contraindicated during pregnancy because no human data exists in lactation. And this is a busy slide, but these are the pharmacological properties of DOACs. So some dose adjustments are required when renal clearance is hindered. And please take a picture of this so there can be some information. Dabigatran, it's a selective thrombin inhibitor. Now the oral formula contains the prodrug and the recommended dose, atrial fibrillation, VTE, I have mentioned again, and it has a relatively long half-life that is strongly influenced by renal function. And there's an antidote available for this, so this is very important. Now the factor Xa inhibitors, apixaban, rivaroxaban, edoxaban, they have the same indications. The dosages depend upon the compound that you are using. The dose adjustments required are shown here, and I won't go individually into the details, but again, antidote is not available. Now, what is the clinical evidence? They all work well. And I have enumerated some trials through which the data has come out. Again, this is being recorded, so obviously you can use it later on. And what is comparison with warfarin? The evidence. The Aristotle trial showed superiority of apixaban compared to warfarin. The Averroes RCT comparing apixaban with aspirin in warfarin ineligible patients demonstrated decreased stroke risk with apixaban. The Engage TB trial compared high and low dose apixaban with warfarin. And so the DOAs demonstrated a 10% reduction in all-cause mortality against warfarin. So this is very important for all of us. And what is the background aspirin therapy? A meta-analysis analyzing patients on aspirin in the DOAC versus warfarin trials demonstrated a pooled reduction in stroke risk and intracranial hemorrhage with DOACs without the difference in major risk bleeding. And this is important. So what are the advantages and limitations of the direct oral anticoagulants? It represents an important advancement in antithrombotic management. Real-world data consistent with their clinical trial data is reassuring. In its careful patient selection, appropriate management, and the ability to prevent and manage the bleeding complications that will permit optimization on the use of DOACs. 10A inhibitors have slightly lower bleeding rates, including lower rates of intracranial bleeds than warfarin. Concerns over the inability to quickly reverse their effects in the setting of major bleeding is still an issue with the factor 10A inhibitors. In routine clinical care, much must be done to familiarize the clinicians. And thank you for your attention.
Thank you, Dr. Patel. Any question from the house?
Thank you.
Dr. Malay, thank you for the talk. Can you just tell me where, if any, would you prefer vitamin K antagonist over a DOAC in a venous thromboembolism case? One, of course, you said was pregnancy.
I think pregnancy is a place. Can you hear me? Yeah.
So do you recommend right from zero day one to start this therapy, or to overlap it with the heparin and then continue?
Yes.
And how long you will give?
Yes. In case of venous thromboembolism, it is best to give this for at least we recommend 3 months, but usually it goes on up to 6 months. So this is something that we would recommend.
And you recommend them in acute thrombosis with heparin or without, with the low molecular weight heparin, or just start this single drug therapy that is your oral anticoagulants?
Initially, if your patient has come with heparin, then you just wait for the heparin effect to wear off and then start this medication, oral medication. Otherwise, you can straight away start with this medication. There is nothing to stop us from doing that.
Any harm of giving them along with the heparin or LMWH?
No, you have to give either one of them, because LMWHs again are 10A inhibitors. So both of them would create a sort of a conflict inside the patient. So best is to give only one of them. And if you are going to use an antiplatelet agent, then use only the mildest antiplatelet agent, because if your patient has been recently stented, cannot get off an antiplatelet agent, then just use aspirin.
So you recommend it along with the aspirin?
If there is a requirement to do this, say like your patient has been just stented about 1 month ago or something like that.
Otherwise, it is not required. Neither heparin nor aspirin, nothing is required. Only single drug.
Yes. Yes, sir.
Yeah. Thank you. Thanks a lot.
Dr. Yadav, with dabigatran, it is recommended to start with low molecular heparin, but with apixaban, Xarelto, you may not give heparin at all. You can just start with it, with the DOAC. Yeah. Yes.
Thank you.
That's correct.
Thanks, Dr. Patel.
So next talk is, thank you, Dr. Malay. Next talk is mine, Dr. Bedi. Can you please, Dr. Amla, can you run my video? That is talk number 5. And I'll be talking on the newest talk number 5. Wait, Harinder Singh Bedi. 5, talk number 5. Respected chairpersons, dear colleagues.
Just a minute.
At the outset, I would like to thank the IACTS for giving us, the Venous Association of India, this opportunity to interact with you. I'll be speaking on newer interventions and devices for treating deep venous thrombosis. No disclosures. Thrombosis is the #1 cause of preventable in-hospital deaths, and that is a huge statistics. The diagnosis of DVT is easily established by clinical features, by lab studies, that is D-dimer, and by imaging, which is usually a duplex ultrasound scan, which is, all of them are very sensitive and specific. Sometimes you may need to do a CT venogram, as over here, showing an extensive clot in the femoral and the iliac veins. That's a clot in the common iliac vein. Rarely, or in the cases that I'll be talking to you about, we need to do an invasive venogram. This should do only in the cases where you are going to intervene with one of the interventional therapies. So that's a dye in the iliac vein showing an acute cutoff due to acute deep venous thrombosis. That's a dye in the femoral vein showing multiple filling defects due to acute deep venous thrombosis. So here you can see there's a sheath in the popliteal vein, and we are injecting and seeing these multiple filling defects, confirming the diagnosis before proceeding with the interventional management. Now, the standard therapy, the aims are to stop or halt the thrombotic process, and if possible, to remove the clot by fibrinolysis, by aiding the natural fibrinolysis, or giving drugs which will be, or devices to remove the clot, which we'll be talking to you about. Now, that's the standard current therapy. You start with up to 5 days of a low molecular weight heparin, followed by an oral anticoagulant, which till now used to be a vitamin K antagonist, but now we have switched over to the direct oral anticoagulant. This is a standard therapy for the majority of deep venous thrombosis. However, what happens if you have a massive proximal iliofemoral thrombosis? The risk of recurrent DVT with just oral anticoagulants is high, and the patient can very easily land up with a post-thrombotic syndrome, which is a debilitating disorder. At 5 years, there is a high incidence of varicose veins, venous insufficiency, venous ulcerations, and there is a markedly reduced quality of life. So what do you do now in the current era? We remove the clot. Earlier, much earlier, we did a few cases of operative removal, but that has been given up. Now we go endovascular, either a catheter-directed thrombolysis, CDT, or a device which I'll be talking to you about. And the latest device we have used in India, that's the Penumbra or the Indigo device. This is the study, the CAVEN trial, which started the whole thought process of doing an intervention. And this showed that if you compared people where you gave a catheter-directed thrombolysis versus just oral anticoagulants, there was a problem in the fact that with the thrombolysis, you had a lower incidence of post-thrombotic syndrome or PTS and a higher patency of the iliofemoral system. So that started the thought process that let us try and remove the clot with something more aggressive than oral anticoagulant. And this has reached our guidelines, and the current indications for intervention are a young patient, massive iliofemoral proximal DVT, acute thrombus less than 14 days old, low risk of bleeding, and a good life expectancy. The method of doing it is very standardized. I'll take you through the steps. Patient is lying prone. Either it can be in the ultrasonography room, or can be at the bedside, or can be at the cath lab. That's, you can see the back of the knee. We cannulate the popliteal vein. You need to be trained in a duplex scan, or you need a good trained radiologist to do that for you. Then you take the patient to the cath lab. You may leave the patient in the prone position, or you can switch him to the supine if that is more comfortable. When you're putting in the cannula and the under duplex, you can see that the venous pressure is very high, and you may initially get scared that have I hit the artery, but no, that is the vein. So you put in a sheath. Through the sheath, you put in a catheter. Confirm the diagnosis always, even if you've done the duplex scan, and then start the thrombolysis. During thrombolysis, We may aspirate. And you can see over here, we can actually physically remove the clot with the syringe. Huge amount of clot can be removed as seen over here, along with the thrombolysis. Now let's get back to the thrombolysis. We put in the catheter. I'll show you the technique in just a while. Another system of thrombolysis is called the trellis system. Here you have two balloons. You go proximal and distal to the clot. Inflate the balloons, activate the system which breaks the clot, and then give the thrombolysis. And later on, either the whole clot will dissolve or you can aspirate the small pieces of clot. So that's another system. So that's the example I'll give you, which we did recently. A middle-aged housewife, case of CA breast, who had had a full course of therapy. She had a swelling of the leg, diagnosed correctly as DVT. Standard treatment started, but then she collapsed. Luckily, she was revived. This was outside hospital. A CT scan confirmed the diagnosis of a massive pulmonary embolism, and she was shifted to us. You can see the leg is swollen. There is this massive CT pulmonary angiogram showing a massive pulmonary embolism, along with which she also had a massive iliofemoral DVT. Now, normally, of course, the cause generally is iliofemoral DVT, but normally this clot has dislodged, reached the lungs, pulmonary artery. But in this patient, it was still over there. You can see it's a huge clot, femoral iliac vein up to but not into the IVC. So we put in two venous catheters, one in the popliteal vein on the side of the DVT, another into the femoral vein, which was normal, and so that we could land up into the pulmonary artery. And we gave, that's the femoral vein. So this confirms the diagnosis. And we also did a pulmonary angiogram and reached the pulmonary artery, which confirmed the massive pulmonary embolism. We use a special catheter called the Craig-McNamara catheter. This has multiple holes so that we can give the thrombolytic agent through the whole length of the clot. That's the cannula. And we give a small bolus followed by a continuous infusion over 24 hours. So that's the catheter, which is being threaded through the clot. This is going through the clot and into the iliac vein. That's where it has reached the iliac vein. So this whole length, it is not just the tip which is transfusing the thrombolytic agent, but the whole length of the catheter, allowing the clot to be bathed in the thrombolytic agent. So that leads to more efficient, and you can see pre and post, the whole clot has dissolved. The vein is back to normal. The valves are back to normal. There is no incidence, no possibility of a post-thrombotic syndrome. And the patient started breathing normally and was walking. So that's about how we do the catheter-directed thrombolysis. There are some more devices like the AngioJet, which is a thrombectomy device. And the latest is this Indigo or the Penumbra system, which is a very advanced suction device. And we have used it in a couple of cases. So that's the suction. You need a very well-trained technician, because while you are manipulating the catheter, the technician is sitting at the suction machine. If the catheter is not in the clot, there will be a sudden suction of a huge amount. That's my technician. There will be a sudden inflow of a large amount of blood. So that's the clot which is being aspirated, and huge amount of clot is removed. This device is especially useful where you do not want to give thrombolytic agent because it is contraindicated. For example, a patient who is recently post-operative.
Good.
After you have done the thrombolysis, it is mandatory to do a completion venogram, because you may unmask a stenosis, which will of course need to be tackled like a May-Thurner syndrome with ballooning and sometimes stenting, but usually we don't stent at that point in time. IVC filters, we have very, very limited indications for IVC filters, and whenever we do put them, they are retrievable filters. So we had one such patient, the recent postpartum had a rather complicated cesarean section, and very soon after delivery had DVT. And the gynecologist obviously did not want us to give any thrombolytic agents because of the recent surgery. So we put in a temporary filter and aspirated the clot. And after a couple of months, a couple of weeks, we remove the temporary filter. So that's the mother with a very healthy child. Very, very rarely, 20 years back, this is the one and only case I have done where we did an operative thrombectomy for a patient with phlegmasia cerulodolens, and we were able to save the leg, but now we don't need to do this because of endovascular techniques. So to conclude, DVT is not uncommon all over the world. Standard therapy is oral anticoagulants, but in the patients which I have told you about, we need to intervene with either a catheter-directed thrombolysis, which is the commonest method, or with devices which can actually remove the clot, and rarely with IVC filters. Thank you very much.
Thank you, Dr.
Any
Bailey.
questions, we'll be very happy to answer.
Now we go to another speaker. Actually, we are running short of time, and some of the speakers of some other session need to start again after this. So directly we go to the next lecture.
Yes. So the next speaker is Dr. Roy Varghese. He is one of the senior most vascular surgeons in India, based in Cochin. He's also a cardiovascular surgeon by training. And I request Dr. Roy to please go ahead. Dr. Roy Varghese, if you're there, or you can run his pre-recorded video. It's a very interesting topic.
Yeah. Yeah. It's visible.
Today I'll be presenting on cardiomyopathy and chronic venous disease. I have two other co-authors. I myself, Dr. Roy Varghese, he is from Cochin, based in Kerala, God's own country, and Professor Malay Patil, he hails from Ahmedabad and is a well-known vein surgeon. Most of the data we collect and we publish in the last 10 years is along with Dr. Manjusha Rajarishi, a PhD in data analysis. We have no conflict of interest and nothing to declare. There is no source of funding. Thank you. Cardiomyopathy is a subject close to the hearts of all the cardiologists, and a vascular surgeon like me has nothing to add to this. Of course, all the vascular surgeons and vein surgeons are interested in the right-sided heart failure and increase in venous pressure for various reasons. The increase in venous pressure may be most of the time because of the right heart problems, and occasionally due to other problems, mainly the iliac vein or the inferior vena cava obstruction or stenosis. We'll come to that a little later. Now, let us understand what is deep vein hypertension. Arterial hypertension is well known. The deep vein hypertension is not known. See, the vein pressure is almost that of the right heart while lying down. When we stand up, what happens is, multiply for a person it's about 180 centimeters height, the heart must be about 20-25 centimeters below. I'll multiply that millimeter of water with the atmospheric pressure. At the ankle, we have almost, say, 120 or 110 millimeter pressure of mercury pressure. So that is why when a vein bleeds, it bleeds just like an artery if the patient is standing. So one has to be very careful. And if there is a destruction of the deep vein walls, what happens is the right heart pressures and the atmosphere plus the atmospheric pressure is directly transmitted up to the ankle. Of course, there is another villain in peripheral edema and venous disease. The mechanisms are pre-capillary arterial vasodilation, sodium water retention, lymphatic insufficiency, and increased capillary permeability. All this adds to vein return and increase in venous pressures. I will not dilate much on this because this is an august audience. Lymphovenous edema. Whenever there is a lymphatic overload, a venous overload, there is a capillary leak, and the the lymphatic edema comes. And the lymphatic edema, when combined with the chronic venous insufficiency, presents with a picture like this. So this is not filariasis, this is not some other hepatic disease. This is a plain and simple chronic venous disease causing excessive overload in the lymphatic tissue and a leg syndrome like this. What one must understand is, whenever there is a lymphatic overload, the dorsum of the foot is swollen. Whenever there is only a venous overload, behind the medial and lateral malleolus, we find edema. In this condition, all the 3 places which I have mentioned have edema. The psychosocial impact of lymphovenous edema or deep vein hypertension is very graphic in this picture. Of course, there is a health and economic benefits of advanced pneumatic compression devices in patients with phlebolymphedema. On the left side, you find how we apply a compression bandage, a 4-layer bandage, and on the left side, on the right side, you find a healed ulcer. More details are available in the references. Whenever there stasis edema, what happens is calcification comes in some bones and demineralization comes in some bones. Here you find a classic picture of the Achilles tendon getting calcified and calcaneal spurs, and also the cuneiform bones showing osteophytes. This is a sequelae of chronic venous insufficiency, phleboarthrosis knee, first described by Roy Verghese, Malay Patel and our group, and enlarged by Professor Old from France, Descartes University. Of course, phleboarthrosis ankle classic, another picture, and a picture of the leg in both edema in both phlebo edema in both legs, now under compression therapy on the second day. Then all the cardiologists must understand there is a peroneus tendon stress syndrome because of the extreme edema, and these patients tend to put on weight. The peroneus group of muscles which gets inserted into the forefoot and ankle, what happens is there is a stress syndrome, and you see there is a edema on the lateral aspect of the dorsum of the foot and also just in front of the lateral malleolus. If you find this syndrome, please refer to a vein surgeon or a vascular surgeon who can deal with this better. You can see the extreme pull on the long tendons, especially on the dorsum side. The fingers are almost emaciated. This is a prime candidate for forming ulcers, and arterial insufficiency also may be there. This is what is known as the black feet syndrome. The whole of the feet becomes dark colored because of the leak of hemoglobin into the body, into the tissues from broken down and being leaking into the tissues from broken down RBCs. The bony changes in chronic venous hypertension are mainly in the cuneiform bones and also arthrosis around the ankle, fibrosis and arthrosis around the ankle. And atypical ulcers is usually a sign of chronic venous hypertension. Usually, as I mentioned earlier on in my slides, has a cardiac etiology. Very few patients have other etiologies, including an iliac vein compression syndrome or a stenosis or an obstruction. Some of them do have liver problems. That is a very minority. What is the take-home message of this small lecture before a very august audience? If you see atypical legs with edema and ulcers in a patient with chronic cardiac insufficiency, think of deep vein hypertension ulcers. Thank you so much.
Thank you, Dr. Verghese. Only one question I want to ask is how you make the diagnosis and what will the treatment? Dr. Verghese?
Dr. Verghese, are you there? Dr. Roy?
Okay, then we go to the next topic.
Yeah, okay.
This is traveling.
Dr. Pinjala, you can answer the question.
Can you repeat the question, please?
How do you diagnose?
Chronic venous insufficiency in cardiac failure. How you confirm the diagnosis that this is only because of this, not because of other reason, and how you treat it? Any special treatment other than the cardiac treatment is
In patients with cardiac insufficiency, the intravenous pressures will go up. When the right heart failure takes place, the pressures in the venous system go up, and there is a likelihood
only,
of.
that's all right. How you confirm the diagnosis and how you treat? Any
Color
other treatment other than cardiac treatment?
Yes, color Doppler scanning has to be done to assess the degree of reflex and the amount of backflow. How many milliseconds does it carry? More than 500 milliseconds of reflex backwards into the great saphenous venous junction, SF junction is significant. Similarly, if the patient has got perforators with 350 milliseconds reflex, they are significant. Such patients can be treated with the laser therapy if necessary to stop the reflex backwards into the great saphenous vein and the perforators. In addition to the heart failure treatment, cardiac insufficiency treatment.
Yeah.
Thank you.
Okay, thank you. Thank you, Dr. Pinjala.
So we move on to Dr. Rahul Jindal, talk number 7 and 8. Dr. Jindal is Director of Vascular Surgery at the Fortis Hospital in Mohali, and he is a senior member of a number of international vascular associations. So can you please start the talk number 7? Put the sound on.
Correct choice of treatment at the right time actually can save lots of limbs and can avoid unnecessary costs. If you look into the current scenario, both endovascular therapy and the surgical bypasses for peripheral arterial disease and diabetes is much debated. And critical limbs have got complicated disease, and these patients are sick. So we feel that the combination of both endovascular and the surgical bypasses can really help this group of patients. So let's say a patient who has got a non-healing ulcer or a gangrene with cellulitis, what we medically call critical limb ischemia, normally have multi-level disease. So what I mean by multi-level disease is that we divide this into 3 parts: an aortoiliac disease, a femoropopliteal disease, or an infrapopliteal crural disease. And now a new terminology has come up, what we call an inframalleolar disease, especially in diabetes. So the people who smokes normally have their proximal lesions, and people with diabetes normally have below the popliteal lesions. So when you have critical limb ischemia, normally you have at least 2 levels of blockage which can be treated. So surgical bypass has got the possible advantages because it's very durable, very effective, but of course has drawbacks in terms of morbidity, mortality, poor long-term patencies, especially in the below knee. Surveillance is required, and of course in obese patients and morbidly sick patients, it's very difficult. Catheter-based interventions has got advantages with non-invasive, can be done with local anesthesias, low morbidities and mortality, can be repeated, and is also very effective. And of course has drawback, sometimes it's expensive, poor long-term patency, and may have to be repeated. Doing an intervention in the patient also depends upon what anatomical factors and where is the blockage. What is the morphology of the lesion? Does it block? Does it got an occlusion or not? Is the lesions are calcified? And how long the blockage is? Especially if you look, the blockages in the aortoiliac segments, they are divided into, according to the task classification, like in A, where very simple lesions, like on the top, to the task D, which is there at the bottom. So obviously, when you have a patient with a task A lesion, very small lesions, there is no point opening the tummy and doing an aortoiliac bypass. This can be very easily treated with a 15-minute procedure with an endovascular route, and the stenting will be the best option. The question comes is when we have a type D lesions, where doing a bypass and in some cases doing a catheter-based intervention has a pros and cons. Similarly, in the femoropopliteal lesions, you will not do a bypass for a task A lesion because that's not right. And doing in task D, all the patients with an endovascular intervention is also not the right way to do. So we need to see which patients we have to do what. And that's why the treatment plan depends upon not only the patient has got a single or multi-level disease, it also depends on other factors like a condition of the patients, like what is the expertise available, what is the type of occlusion, populatory artery is opened or not, what is the runoff, and how much is the soft tissue destruction. So let's take a few examples. Patient has got a bilateral SFA occlusion. Now, on the left side, this patient will do very well with an endovascular intervention. And on the right side, it's a task B. It will also do well within endovascular, and if the patient is sick, but it will also do very well with a femoropopliteal bypass. Similarly, another patient, 71-year female, got a very long occlusion, you can see from the femoral, and the only runoff vessel is an anterior tibial artery. Now, doing an endovascular intervention in such a patient, and if you do a very long intervention in such a case, it involves a lot of costing, success rate of endovascular is poor, and it's a single vessel runoff, then a vein bypass, if the patient is fit, really gives you a very good results and long-term patency. So we did an femoral anterior tibial artery vein bypass in this patient. So let's say this patient has got a critical limb ischemia, this is at the level of knee and angiogram, a popliteal artery occlusion with an anterior tibial, perineal, and posterior tibial lesions. Now, if you have to treat this patient, one option is you do a bypass from popliteal up to a distal artery, which is of course requires a lot of cutting. But this lesion is also very good for an endovascular intervention. And you can see within 1 hour procedure under local anesthesia, you can get a fairly good result. So endovascular intervention should be the treatment of choice. What about this? Patient has got a huge aortoiliac occlusions. So if the patient is fit, then this patient of task D should be better dealt with a bypass, and aortobiofilm really gives you very good results. But once the patient is very sick and very old, where the survival is not more than 2 to 3 years, so then doing an bilateral aortoiliac stenting also is not a bad option. The whole procedure can be done under local anesthesia. Patient can be discharged next day with nearly less than 0.5% mortality. Let's take 1 or 2 examples. Now, case 1, he's a claudicant with a multi-level disease. You can see he's got a very poor runoff behind. And if you look at the CT angio, if this patient just had claudicant, I will just do medical treatment. If this patient had a very bad critical limb ischemia, then this bypass is not the right thing to do. So because the patient has got very poor runoff, doing such bypasses normally will not run for very long time. So this patient could have been dealt with either medical or could have done with an endovascular intervention, or you can do a hybrid. What a hybrid means, you do this bypass, and at the distal end and anterior tibial artery, you do a distal angioplasty to improve the runoff so that these grafts can run for much longer time. The patient has got critical limb ischemia here with a heel gangrene, very bad infection. We did a bypass and an angioplasty, and they can see then the heel, with a vac pump and antibiotics can give you a very good result. So just having a calcaneal osteomyelitis should not be an indication for an amputation. Another example of 65 years, patient just had a myocardial infarction, presented with sepsis because of left leg critical leg ischemia. Look at the ejection fraction and normal creatinine. Patient is on BiPAP and very critical limb patient. You will not be like to do anything very big in this patient. So when you see a CT angiogram of this patient, you can see very bad on the left side common iliac lesion and long distance femoral popliteal occlusion with a good runoff. So what will you do in this patient? You can't do an aortopopliteal bypass because you have to open the tummy up and patient is very critical. So these type of patients do very well with hybrid procedures. So what we do is we open up the common femoral artery here. We do a reverse iliac stenting. in this patient in such a theater in a hybrid, and such a foot looking bad looking foot what we have. And what we do in such a patient, we go and do a reverse iliac stenting, and at the same time from the femur up to the popliteal we do a femoropopliteal bypass, PTFE bypass, which can give you a very good results. And once you do the bypass and then you do the debridement and do the vac pump, and this can give you very, very good results, and we can save such foot in a very, very critical limb patients. Another very bad critical limb ischemia you can see, normally these patients have multi-level disease, and what we did in this patient, we did a femoropopliteal bypass, but you can see the runoff was very poor. So what we did, we put in a sheath into the popliteal artery, and then we took a runoff, and then we did improve, did an angioplasty and open up both the peroneal artery and the posterior tibial artery runoff. And so this patient had a hybrid of a femoropopliteal bypass and then an infrapopliteal angioplasty to improve the distal blood flow. And then these limbs, they heal up very nicely, and you can save these limbs and give a very good treatment to this group of patients. A last example, a patient has got a recent myocardial infarction, left critical limb ischemia, has got a raised creatinine, and MR angio shows a left iliac occlusion. So now the ideal situation is to do an aortofemoral bypass if the patient is fit enough, but the patient is not fit. Patient is actually not fit for any anesthesia. So what will you do? So under local anesthesia, the patient has got a lot of rest pain. So what you can do is you can open up both the femoral arteries, you can treat the right common iliac artery lesion with a stent, and then do a femorofemoral popliteal bypass. And at the same time, you can also do the right profunda artery plasty. So what we did, we opened up the groin under hybrid, under local anesthesia. We placed the right iliac stent here, and we did a femorofemoral bypass, crossover under local anesthesia. And with this hybrid, you can actually get rid of the problem and without causing much stress to the patient's body. So endovascular interventions are rising if you look into the literature, but we feel all these complex cases with the endovascular interventions, when we combine them with surgery, they can give us a very good results. So both means are very, very important for revascularizing these complex patients. And the choice of intervention will depend upon the degree of ischemia, the extent of the arterial disease, and the wound damage, and the presence or absence of infection, and what is the local expertise which is available.
Thank you, Dr. Jindal. We can go directly to your...
The critical limb ischemia is a very complex thing, and with the combinations of both open and endovascular, we can really save a lot more patients, which we were not able to do it. Thank you.
Dr. Bedi, can we go directly to his next lecture?
Yeah, that is by the same speaker, and it is talk number 8.
Time issues there.
Yes, we have 2 more talks to go. We are well in time. Can you please run the talk number 8?
Today we're going to talk about recent advances in treatment of varicose veins. So we all know, how does the varicose veins happens and the pathophysiology. And we also know that in 2020, there has been a new SEEP classification mentioning about recurrent varicose veins, all the details about C4 changes in the skin, and also about the recurrent active venous ulcer. We also know that there are multiple treatment options which are available, and you don't need to know all of them, but I just want to show you what all is available in the world. In terms of surgery, minimal invasive surgery under local anesthesia and Timmerson's anesthesia with ultrasound marking can be performed in the centers where laser is not available, and patient can walk home with very good results. In terms of laser, The new thing which is there is a 1940 nanometer laser as compared to 1470, which has got a higher absorption in both water and also in the vein wall, causing less bruising, less cord formation, and more veins which are very close to the skin can be treated. In terms of laser fibers, we used to have single rings, then a double ring fiber. Now we got an infinite laser fiber, which have got 5 rings, burning the whole segment of 1 centimeter with the laser ablation. Let's take an example of a huge varicose veins. Patient has around 22 millimeter long saphenous vein with incompetent saphenofemoral junction. We placed a 6 French sheath in the mid thigh with a laser fiber over there. And once you have such a huge incompetent saphenofemoral junction, you need to ablate the vein very well. And along with the foam sclerotherapy, you can get a very good results. What is new is that in the patient who's got a huge saphenofemoral junction, we found that if you don't treat the junction very well, we used to have a recurrence of the varicose veins from the anterior thigh vein. So what we do is in this is a thermal cross-sectomy. What that means is you take the laser fiber absolutely up to the saphenofemoral junction. You have to be very careful. You have to give the tumescence to create a junction and the angle over there so that the heat energy does not go into the common femoral vein, causing a DVT. You have to be very, very careful in doing this procedure. And in some particular cases, this procedure can be useful, but in routine cases, you should keep laser fiber around 2 centimeters away from saphenofemoral junction. So look at this patient. He has a huge SFJ. We take the laser fiber up to the SFJ and close it from the junction, causing a very good result. Similarly, new development, if you have got a smaller perforator, you can close it with the foam sclerotherapy. If you have a bigger perforator, you can use a laser fiber or an RF fiber and can cause the closure of this perforator along with the tumescence anesthesia. So in this patient, we have placed the tumescence anesthesia and we are closing the perforator through the laser and RF, giving you a very good results. Then another thermal techniques which are available in the market are a radio frequency ablation by F-Care and also by a Medtronic. Then we've got a steam ablation. It's a device called a V-Box. Then we also got a microwave technologies. So all these thermal technologies, we have been using it from the 4 years in our center, and every technology has got pros and cons. I still feel that the laser technology is one of the best technologies available with us today. Then we got the non-thermal techniques where we use the foam and the glue. The foam sclerosant, what we do, we take an STD or a polyductanol, we mix it with the air and we create a foam. So you can either use a simple foam sclerotherapy, which does not have a very good closure rate, but is very cheap. Then we can also use a mechanical damage of the vein wall along with the foam with 2 devices called as Claravin and Flabograph. They are called as MOCA techniques. Both have got their different ways of functioning. One uses a liquid sclerosant, another one uses a foam sclerotherapy. We can also combine this with a foam sclerotherapy or a phlebectomy in the legs to give you the best results. So let's take a look at this animation where we take the Flabograph device up to the saphenofemoral junction. There is a protocol, how do you close it? Then we scrap the veins inside and then we put in a foam sclerotherapy, and that also can give you a very good results in this group of patients. Then there are 2 types of glue available in our country. One is an Invamed, a Turkish glue. Another one is a Medtronic glue from US. Both have got pros and cons. There is different technique. How do you use these glues? I feel the indications will be in obese patients where you cannot use local anesthesia, tumescence anesthesia, where you're doing it in a very smaller setups, where you don't have hardware, like laser machines or radio frequency machines. So these techniques also have got a place in the armamentarium. Coming to the last technique is a high intensity focus ultrasound. It's in an experimental technique, which is being used in UK. Transdermally, we place a focus ultrasound on the vein and damage the intima and the media and causing a sclerosis of the vein. So we will know its results in another 1 to 2 years. And at present, the machine is very expensive. It's not practical to use it in every center. Coming to the last topic of cosmetic varicose veins, where we treat the spider and the reticular veins. There are various methods to treat these veins. One of the famous methods is a Clark's technique, where we use a transdermal laser along with the sclerotherapy and the skin cooling under augmented reality. So 1074 ND-Wig laser we use here. And this is one of the patients where we are using a 6 mm spot here. The red dot which you can see is a laser fiber. And the green color thing is an augmented reality. What we are doing is we are burning the vein transdermally, and there is no local anesthesia which is required. Once you have done this, then you can take a 30 gauge needle, very small needle, and put in a sclerosant inside the vein and cause the closure of the vein. The advantage of this technique is you can get a very good cosmetic results because you use a very low dose of sclerosant. We found this is very useful for foot veins where you don't want to cause a skin necrosis. And we can also use it for cosmetic purposes where you have patients coming with you with spider veins. The last topic will be bulbar varicosities, where you get these veins because of the pelvic congestion syndrome. So if you have a very small amount of veins, you can use a sclerotherapy. But if you have got a big veins, you need to close the left ovarian or the right ovarian veins. We go under local anesthesia through the internal jugular vein into the ovarian vein. We take a venogram and place some coils or glue inside. So in conclusion, treatment for the management of varicose veins is evolving, very patient friendly, and minimal invasive treatment is a very important and is a gold standard in today's time. Thank you.
Thank you, Dr. Jindal. You got wide experience of treating varicose vein with surgery with these laser, RFA. But after all these things, still you consider somewhere some role of the surgical procedure also?
Yes, sir, definitely. There is a role for open varicose vein surgery. So I will start with the basic thing. One is if you look into more than 300 medical colleges, what we have, and if you look into the periphery, the general surgeons who are operating, everybody cannot have an access to an ultrasound.
That is not the question. Because the patient is coming to you and now you are the only decision making.
Okay. I'm coming to that, sir. So this is one of the indications where if you don't have the facilities, you can do an ultrasound guided intervention. So second will be, there are a lot of patients where you have a saphenous varices. So means the saphenofemoral junction and the saphenopopliteal junctions, they are more than 20 millimeters. So sometimes you see them 4 centimeter long, big dilated junctions which are incompetent. So we tried closing them with a laser long time back. So what we failed. So all those patients, we recommend them that we do an open interventions under local anesthesia. So besides that, I don't see any other indications for doing an open interventions nowadays.
Okay. Thank you.
Yeah.
Thank you. Dr. Bedi, can you go to next
we
lecture?
go on to Professor Ajay Khanna, who is Professor of Surgery at the prestigious oldest university of India, the BHU. And he's a prolific writer also and a trainer of surgeons. So over to you, Dr. Ajay Khanna.
I'm really thankful to Dr. Bedi for
My topic is matrix metalloproteinases, MMP, and its correlation with the chronic venous insufficiency. I'll be discussing this topic under the heading of the what is MMP and what are the various types of MMPs, what is its relation of the MMP to the CVI, our small research work which we have done on the MMP, and do we have any treatment based on the MMP, and what are the future prospects. So if we look at the varicose veins as such, what is the pathogenesis is still not understood. It can be because of the reflux, incompetent walls, obstruction, venous dilatation, various type of genetic factors are there, and also various other factors like the MMPs are also responsible for causation of the varicose veins. So MMP is a type of the endopeptidase which was described in 1962 as a collision proteolytic activity during the extracellular matrix protein degradation. They are highly homologous zinc-dependent endopeptidases that cleave most of the constituents of the extracellular matrix. There are various enzymes. This MMP enzymes is involved in various type of the activities in the body, like even in the embryogenesis, or if there's a tissue healing is there, or remodeling of like the veins which is there, or if somebody has got the malignancy, the metastasis, and in the chronic wounds, MMP enzyme plays an important role. And in the venous system, it can involve all the layers of the venous wall, including the extracellular matrix, leading to the venous wall degradation, varicose vein formation, and also ultimately leading to the venous ulcer. So if you look at this picture, it is like the normal vein. Then this is when there is involvement of the MMPs here, and then the reactive oxygen species, they come here, and finally we get the venous dilatation like that. So what are the various types of the MMPs? Almost there are 28 described types of the MMPs are there, and 23 in the humans and rest in the experimental animals. And almost about 14 MMPs are there in the vascular tissue. But there are 5 major types like the gelatinases, the collagenases, stromoglycans, the matrilysins, and membrane type are the main MMPs which are studied and are responsible for the CVI. We did a small study on 75 patients, and we looked in all these the various levels of the MMPs, the MMP 1, 2, 9, 13, tissue inhibitors of the MMP, and 1 and 2. When we looked at the MMP1 expression by the immunohistochemistry, we found that there is a definite increase in the expression of this in all the layers, intima, media, as well as the adventitia. MMP2, we did not find any increased expressions, while it was normal or even the absent expression in the case of the MMP2. MMP9, almost half of the patients, they had involvement found in all the 3 layers. 13, again almost about half of the patients had involvement all in intima, media, and adventitia. And surprising, the TIMP1 tissue inhibitor, we did not find any increased expression, neither TIMP1 or 2. Both we could not demonstrate the MMP expression. And then we correlated this MMP1 and the other MMPs with the C grading of that, and as it is increasing here, see the MMP are more, so C5, 6, almost about 100% of the patients, they had the increased MMPs. Similarly, MMP9 also in C6 almost about 100%, 13 also it is around 100%. So these MMPs which are there, they are responsible for the causation of the progression of the disease and also the disease itself. So we concluded our work that MMP 1, 9 and 13 overexpression is more likely associated with the severity of the disease. Tissue inhibitor MMPs are less likely to be involved in the formation of varicose veins. They may be involved in etiopathogenesis as the severity of the disease. So can we target the MMP by anything? We have seen that in various types of chronic ulcers which are there, whether it is the diabetic foot ulcer, the pressure ulcer, or the venous ulcer is there, the MMP's levels are high. So we can target the MMP, and there are different physiological processes and in the pathogenesis of the specific disease that you can do a targeting of the MMP to take control of that. So what are the various types of the MMP inhibitors which are there? Like there are tissue inhibitors which are there, and then the pharmacological inhibitors like the zinc chelators, the doxycycline, and merimestate which is there. These are the few types. There are many others also which are there. But this is a good part that the doxycycline is the one drug which has been approved by the Food and Drug Administration for the high MMPs. And in fact, in our patients of the venous ulcer, we do give the patient the doxycycline apart from the compression stocking which is there, or giving the patient the flavonoids. We definitely also give the patient the doxycycline in the dose of about 100 to 200 milligram per day for about 1 to 3 months. Then do we have any MMP based dressings? Yes, they are there. They are there in the market, but I think probably it is not available in Indian setup still. But the nano oligosaccharide factors which are there, the what is called the TLC, NOSF matrix dressing are there, or the oxidized regenerative cellulose or the collagen is there, and they are supposed to decrease the MMP, and there is a definite improvement in the wound area after using these dressings. In vitro studies, it has been shown that this can be used, this NOSF dressing, and this is one of the dressing like the Ergostar which is there. You find that this is the MMP inhibitor dressings. So friends, MMPs are important in the CVI and probably also for the progression of the CVI, because we have seen that in the C1, 2, the MMP level may not be high, but when it is C6 level is there or C5 is there, definitely the MMP levels are high. MMP directed therapies may help in healing venous ulcer. We can use the doxycycline, which is anti-MMP, for the patients who have got the venous ulcer. And MMP directed therapies may also help in reducing the progress of the disease also. So one can do that. You can give the patient the doxycycline, or you can use the various types of dressings for the venous ulcer. But still, I think we have to see for that, can MMP directed therapies be used as the prophylactic agents to prevent the varicose veins, especially in the high risk cases. So this has to be seen. I think the work is going on that can we use the MMP inhibitors for this purpose. Thank you very much.
Thank you, Dr. Khanna. Is this this is hello?
Yeah, we can hear you.
Yeah. So this is working as an antibiotic or some, what is the mechanism of action of this doxycycline?
It is a scavenger of MMPs.
It is not used as antibiotic, but it is the MMP targeting inhibitor.
Okay.
So this is a very interesting topic, even in aortic aneurysms, and I think it will have more of a significance later. So I call upon Dr. Suvira John, who's a senior surgeon in the Gangaram Hospital, and he's special interest in venous thrombosis, and he's on most international and national panels which give the guidelines for prevention of venous thrombosis. And I think this is one of the most important topics that he's talking on. So over to you, Dr. John.
Of cardiovascular and thoracic surgeons, it is my prime clinical duty to highlight the prevention of avoidable hospital-associated venous thromboembolism in every patient and all the time. We now are very well aware that hospital-associated venous thromboembolism is a leading cause of premature deaths worldwide. Sadly, hospital-associated venous thromboembolism accounts for more than half of all venous thromboembolism. Interestingly, this can be prevented in over 70% of patients, but tragically, less than half of hospitalized patients receive any form of appropriate prevention globally. Thus, it is the responsibility of every healthcare worker to prevent venous thromboembolism in hospitals. Clinical leaders in the country highlight the fact that the prevention of VT in hospitalized patients is the #1 patient safety measure in India. How do we achieve this? In practice, this requires a complete 360-degree re-engineering of our hospital professional ecosystem. This starts very simply by recruiting top-level clinical and administrative commitment. This should lead to a mandate of an universal institutional VT prevention policy, enabled both by regulatory commitments as well as by accreditation mandate. This should be followed by administrative measures by the institution of a HAVT prevention committee or group and the creation of an institutional policy and protocol document to prevent HAVTE. The absolute universal mandate to include the prevention of HAVT in routine clinical decision making is absolutely necessary. One must also aim for cultural change in the hospital by including in educational and training initiatives in the hospital the prevention of VT, as well as including this in internal CME processes, as well as screening and surveying for hospital-associated venous thromboembolism and providing the feedback also through periodic audit to the clinical divisions. At our institution, we made a start years ago, building up from what individual departments were doing to creating a singular hospital or institutional hospital-associated venous thromboembolism prevention initiative. This began by gathering a group of committed clinicians and nursing staff and setting forth a policy and protocol document which outlined the clinical pathway, beginning by risk assessment for thrombosis and bleeding, the creation of an order set, the implementation of a VT prevention care bundle, followed up by surveillance and audit processes. Of note, we have a very clear algorithm to help clinicians prevent venous thromboembolism in hospitalized patients, beginning by ruling in or out pre-existing venous thromboembolism, and in the absence of which a thrombotic and bleeding risk is carried out. This is combined to create an order set, and this is then executed by the staff and nursing personnel. We have been very objective at every stage, starting in the process of clarifying the presence or absence of pre-existing VT by outlining a clinical objective evaluation of our patients by using the Wells score for DVT as well as for pulmonary embolism, overlaid by, if necessary, a clinical consultation by a vascular physician or by focused investigation. Once the stage is through, we risk assess for thrombosis in surgical patients, for instance, using the Caprini risk assessment model. Once clinical data is available, the calculation of the Caprini VT risk score takes under 2 minutes for even a nurse. A bleeding risk assessment is done using a list provided by Bell et al., and this also includes leeway times for anesthesia and surgical interventions. Using a combination of both the thrombotic and bleeding risk assessment, we create an order set for preventing VT in the given patient, which is vetted and then attested by the admitting consultant, or in an emergency by the admitting resident in consultation with the consultant. We're also in the process of creating public and patient awareness media and brochures to help recruit patient and family cooperation and compliance with VT preventive strategies in the hospital and post-discharge. Finally, we capture compliance data through our VT Care Bundle checklist. This data is planned to be plowed back through the feedback loop to benchmark our outcomes. Already, VT prevention awareness and training initiatives are in place amongst the nurses and doctors. And despite the slowdown by the COVID pandemic, we hope to accelerate this in the coming years. We've been instrumental and fortunate to have been involved in certain international and national publications for venous thromboembolic related data and evidence in our clinical care. We've also led through 4 national conferences, leading finally to the inclusion of the prevention of hospital-associated venous thromboembolism in the National Patient Safety Implementation Framework 2018-2025, the operational guidelines of which are awaited shortly, and this hopes to include in the surgical safety checklist the capturing of data relating to the implementation of VT preventive strategies in surgical patients during hospitalization. Thank you very much for a patient listening.
Thank you, Dr. Suviraj. That was a very illuminating talk, and especially important considering that in India, at least, as Dr. Pinjala, the first speaker, had shown us, only 50% of the patients who need thromboprophylaxis actually get it. And this is almost international, but I think it is improving now. Thank you for sticking to time. And any questions for any of the speakers, including Dr. Suviraj, we'd be happy to answer.
Any question from the house? No, sir, it's enough. Very good talk, and we enjoyed it. Nearly you completed covered almost all the topics of venous diseases, and we feel highly obliged of you. Thank you. Thank you,
Dr. Yadav. We are the Venous Association of India is especially thankful to you, Professor Yadav, who has organized this mega conference. And today it's the last date, and it has been a major success. So I thank all my co-speakers because they have stuck to time, and actually we have been very good in time. We still have 5 minutes. So thank you, everyone. Thank you, Dr. Yadav.
Thank you very much.
Okay.
Thank
Bye-bye.
you.
Bye.
Thank you.
Bye-bye.
Bye-bye. Thank you. Thank you, Rahul.
Bye, sir. Bye.
Very good to see everyone. Thank you.
Bye-bye.
Thank you.
Thank you for the interactive session. Now we would like to move on to our next session, that is a free paper session. I would like to call upon the moderators on stage, Dr. K.K. Sahu sir, Dr. Ram Gopal Yadav sir, Dr. S.K. Sarkar sir. Kindly join the stage, sir. Now I call upon Dr. Sufina Shells to present her paper on incidence, outcome and predictive factors of post-operative atrial fibrillation in patients undergoing off-pump coronary artery bypass grafting, a prospective observational study.
Good afternoon, everyone. I'm Dr. Sufina Shales from R. N. Tagore Hospital, Kolkata, here to present to you our prospective observational study on incidence, predictors, and outcomes for post-operative atrial fibrillation in Indian patients undergoing off-pump CABG. From our experiences in the post-operative ITUs, we know the incidence of post-op atrial fibrillation is pretty common, and we know the impact of post-op atrial fibrillation on morbidity and thereby increasing hospital resource utilization. So we reviewed literature. There are studies that revealed incidence of 30% of post-op atrial fibrillation. This is an Indian study very similar to our study with a sample size of around 500 patients. This is another Indian study done on post-op atrial fibrillation, but this study included a heterogeneous subset of population. Vis-a-vis, they are including all patients who had coronary revascularization on pump, off pump, and also valve surgeries. So the lacunae in literature that we identified were that most of the studies were done in Western population, which means that considering demographic changes to the Indian population, we cannot extrapolate their studies to ours. And the Indian studies we studied had sample size of very small sample size, mostly done on heterogeneous subset of population. And the design of study was usually retrospective. So we aim to predict the incidence of postoperative atrial fibrillation in patients undergoing off-pump CABG. And objectives were to identify the predictive factors and impact of postoperative atrial fibrillation in postoperative outcomes. We also try to assess the predictive ability of Euroscore and the STS score. Coming to the methodology, ours is a prospective observational study done over a period of 1 year on patients who underwent primarily isolated off-pump coronary artery bypass grafting. We excluded patients who underwent reoperative, concomitant, or emergency surgeries. We also excluded patients who had a history of pre-op diagnosed or treated AF and patients who underwent coronary revascularization on pump. Coming to the results, we find that out of 1,100 patients that we studied, 1,108 patients that we studied, 88 patients had postoperative atrial fibrillation, which is a meager amount of 7.9% compared to the 30% that was reported in literature. Age is a very significant predictive factor for post-op atrial fibrillation. You can see that patients less than 40 years did not have post-op atrial fibrillation. Chronic renal failure is another significant post-op predictive factor, as is left atrial size enlargement and left ventricular internal diameter at systole. Preoperative use of diuretics was another significant predictive factor. Going to postoperative complications, we find that almost all of these postoperative complications that we studied were significant in for patients with postoperative atrial fibrillation. You can see that there are significant respiratory complications, CVS complications, and neuro complications. Death in hospital in our study was not very significant, and we do not have data for long-term outcome. It significantly increased postoperative stay as well. On logistic regression studies, we found that age more than 60 years, unstable angina, diabetes mellitus, left atrial size, and preoperative chronic renal failure were significant predictive factors. This graph shows us that on postoperative day 3 is when postoperative atrial fibrillation, incidence of postoperative atrial fibrillation was noticed maximum. This is an ROC curve, which is basically a graph between true positivity rate and false positivity rate. ROC curve is receiver operative characteristic curve, which is basically used to assess the diagnostic ability of a test. So here we see that the Euroscore and the STS scores are plotted, and you can see that the area under the curve of both the curves are similar and is above the baseline, which means that both the Euroscore and the STS score have a satisfactory and similar diagnostic ability, which means that we can use the Euroscore and the STS score for any risk assessment we need to do for postoperative atrial fibrillation. The limitations of our study was that it was a single center study and we studied only off-pump CABG patients. We did not have a control arm with on-pump surgery, so we cannot with authority say that off-pump surgeries are protective. It was mainly done on younger patient population, so we cannot really extrapolate our study to the elderly population. And postoperative respiratory, renal, and cardiac complications we know can either cause post-op AF or can be the effect of post-op AF. So we do not have any definitive data for that. To summarize, ours is a prospective study done on 1,108 patients who underwent isolated off-pump CABG. 88 patients developed POF, which is around a meager amount of 8% compared to the 30% reviewed in literature. Both Euroscore and STS score showed satisfactory and similar discriminatory ability. To conclude, the rate of postoperative atrial fibrillation we observed was much lower than the previous studies. None of the patients below 40 experienced post-op atrial fibrillation. Post-op atrial fibrillation significantly increases adverse outcomes and length of stay, thereby affecting resource utilization. Both the Euroscore and the STS score are satisfactory and similar discriminatory power and can hence be utilized for risk assessment for postoperative atrial fibrillation. Thank you, sir.
Any questions from the audience?
Ma'am, most
Less than 60 or more than?
no. Can I have the slides, please? We've taken all age groups, but then more number of patients were less than 60 years of patients. So we cannot really,
Okay.
with authority, say that age is.
Age is there. What was the management you used for atrial fibrillation later on?
Ma'am, we in our institute, we usually go by rate control more than rhythm control. We usually use amiodarone and sotalol if their left ventricular ejection fraction is acceptable.
Only
And we
pharmac-
may or may not use anticoagulation depending on the patient
only
condition.
pharmacotherapy is used.
Yes, sir.
This is
Only
post-operative.
pharmacotherapy. We have not
Post-op.
done any
And what
surgical
does
management.
mean by post-op? Post-op means it is 24 hours, 48 hours, 72 hours.
Sir, 72 hours.
72.
48 hours onwards, we have considered any post-operative atrial fibrillation. And we have seen that usually the incidence is on from day 3 onwards.
Or how many patients revert this AF?
So I do not have data for that. I'm sorry.
Is there any role of intraoperative LA appendage ligation?
So we do not do an intraoperative LA ligation. We did not do that in our study. We did not consider that aspect in our study. So I will not able to give you data on that.
But do you have any insight?
But from literature that I have read, yes, intraoperative LA size reduction does help in reducing AF incidence. Thank you.
Okay.
Thank you.
Okay. I would like to invite Dr. Anirudh Kumar Bedi, early and modern results of coronary embolectomy and arterectomy in difficult disease coronaries. Diffusely.
Thank you, sir. Good afternoon, everyone. I am Dr. Anirudh. I'm here to discuss regarding the early and midterm results of coronary endarterectomy in diffusely diseased vessels. The incidence of coronary artery disease is on an increasing trend. The profile of the patients coming for the coronary artery bypass grafting is also continuously changing to include younger patients with associated comorbidities such as diabetes mellitus, hypertension, smoking, and peripheral vascular disease. So there is an increasing use of non-surgical methods also of coronary revascularization, catheter-based methods. Now patients with severe diffuse coronary artery disease are being referred for surgery when the affected vessels are not usually graftable, and complete revascularization using conventional CABG may not be feasible. It is well documented that incomplete myocardial revascularization procedure adversely affects the outcome of CABG. So the options left to surgeons in this group of patients is either to leave them inoperable to do incomplete revascularization, or to do a complete revascularization along with coronary endarterectomy of the vessel along with CABG. So coronary endarterectomy has been used as an adjunct to surgical revascularization. It was introduced late in 1956 by Dr. Bailey, but for some reasons it was soon abandoned due to unfavorable results. The technique was infrequently used by the surgeons because of the following reasons: either due to high operative mortality and morbidity, poorer clinical outcomes, and technical difficulty and uncertainty surrounding the procedure. Later, the reports of Johnson and Cooley, who performed a large series of coronary endarterectomy, revealed that though there is an increased risk, it has good long-term benefit in a selected group of patients, and the need of an endarterectomy overtakes its disadvantages. Recently, there has been renewed interest in the procedure after publication of papers stating judicious use of endarterectomy can give appreciable results with good long-term course. So in our center, both on-pump and off-pump coronary endarterectomies are done, with a large majority of cases being done on CPB. The cases studied here belong to both the groups. So aims and objectives: analysis of pre-op variables in patients who have had coronary endarterectomy, analysis of immediate and early post-operative variables, and comparison of general outcome of patients who have undergone CABG with and without coronary endarterectomy. This is a two-arm prospective and retrospective study which included population who underwent CABG in our institution in a span of 1 year. And the inclusion criteria: the patients with an established coronary artery disease and who has indication for CABG. CABG with coronary endarterectomy, and group of people with who did not undergo any coronary endarterectomy. We excluded redo CABG and concomitant cardiac surgery. A total of 100 patients were identified having diffusely diseased coronaries, out of which 50 underwent coronary endarterectomy in addition to CABG and were statistically analyzed. Sorry. All the patients were offered a review angiography after 6 months of regular follow-up. Statistical methods, we used SPSS software, and P less than 0.05 is considered as statistically significant. We analyzed the following preoperative characteristics like age, smoking history, hypertension, diabetes mellitus, COPD, dyslipidemia, family history, peripheral vascular disease, neurological, any previous neurological attacks, renal impairment, previous MI. We compared both the groups, and these two groups were not statistically significantly different. Coming to surgical technique, the patients were prepared and operated on by standard techniques, median sternotomy, pericardiotomy. A myocardial stabilizer is used in case of off-pump CABG surgeries and cardiopulmonary bypass, systemic hypothermia, antegrade and retrograde cardioplegia, along with topical cooling in case of on-pump CABG surgeries. Most of the endarterectomies were planned preoperatively, but the final decision was taken on the operating table after inspecting the coronary artery. All the patients who were planned in before for coronary endarterectomy were loaded with 325 milligrams of aspirin 1 day before surgery. So coming to surgical technique, on the coronary artery, a liberal incision was made, and entering the correct plane was given the utmost priority, which was just below the external elastic membrane. And an endarterectomy spatula was used to identify the correct plane of dissection and to mobilize the plaque proximally and distally also. A combination of gentle traction on the plaque and counter traction on the adventitia was used to extract the plaque outer. In case of difficulty, in case of more branches or broken plaques, incision was extended and the whole plaque was removed. The optimal removal and completeness of the plaque was determined by seeing the smooth tapering end and palpating the distal part of the vessel. Here we are trying to remove the plaque with gentle traction on the plaque of LAD, and we were able to remove till the soft end along with a small branch at the apex. This characteristic dictates the length of the arteriotomy, then either a long arteriotomy on the lima with direct anastomosis, if it is feasible on the vessel, or closure of the vessel with a saphenous vein patch, onlay patch, and the anastomosis was done to the onlay patch. Postoperative care, postoperatively, the patient was observed for 1 to 2 hours, and if the drain is less, they are started on heparin infusion at the rate of 500 units per hour. Clopidogrel and aspirin were given on the same day if there is no significant bleeding. The patient will be started on acetrom, and heparin infusion will be continued till the INR is more than 1.5. Acetrom is continued for 3 months, and later the patient is switched on to dual antiplatelets, clopidogrel and ecosprin. The primary aim of INR between 1.5 to 2.5. Coming to discussion, these were the endarterectomies. LAD 20 endarterectomies we have done, and RCA 22. And coming to postoperative statistics, we used lima in most of the cases. So usage of lima was not significantly affected due to endarterectomy. However, it being a more invasive procedure, the operative duration was statistically significant from the other group. The postoperative blood loss and transfusions were not significantly different. They needed more monitoring. So ventilation, when the mean ventilatory time, hospital stay, and postoperative ICU stay also differed in both the groups. Otherwise, there is no significantly different. They are not significantly different in renal failure, neurological impairment, IVP requirement. The postoperative MIs, arrhythmias, and mortality was also not statistically different from the other group. These were the some of the. This is a single vessel endarterectomy, LAD, and this is a double vessel endarterectomy. And even we have done a triple vessel endarterectomy also. So conclusion, coronary endarterectomy is the procedure of choice in patients presenting with severe and diffusely diseased vessels with their immediate and early postoperative period, including morbidity, mortality, which is not significantly different from the patients who underwent CABG. I have taken consent from all the patients, and there are no conflicts of interest. Thank you.
Thank you, dear. there is only difference is time.
Time, yes,
It
sir.
takes longer time. The results-
Intraoperative time and ICU stay and hospital stays.
hospital stay. Right.
Yes, madam.
Results of on-pump.
That study is a different study, madam. I'm just doing that here still. Now, in that particular period of time, we have done both on pump and off pump, madam. That
Why did you go on pump?
because if it is very severely disease and extensive arteriotomy, that we have done on pump, madam. Even 2 endarterectomy also we have done on pump. Most of the patients we have done on pump only, madam. Yeah. Thank you.
Do you have any question? I would like to invite quicker, cost-effective and safer method of mitral valve replacement surgery. A study of 64 patients by Dr. Vamisnadhar.
Good afternoon, everyone. I am Dr. Vamshidhar from Krishna Institute of Medical Sciences, Rajahmundry, Andhra Pradesh. So this is a study of 642 patients where we followed a technique for mitral valve replacement where the native valve could not be spared. So this technique led to a quicker, cost-effective and safer method of replacing the mitral valve. Okay, so this article describes the techniques that we followed in 642 patients. Firstly, to optimize the exposure of mitral valve, reduce the aortic cross clamp time and thereby cardiopulmonary bypass time. Next, to preserve the left ventricular geometry and apply the procedure for any pathology where the valve could not be spared and make it technically simpler. This is a prospective cohort study. 642 patients were involved, and the study was between 2010 to 2020 in our institution. And I will describe the surgical procedure in the next video. And echocardiography was done in the preoperative period, immediate postoperative period, at 1 month follow-up and at 1 year follow-up, and the results were analyzed. And here, the part of SVC is dissected from the pericardium. And the plane between superior vena cava and right pulmonary artery is created so that the left atrial incision can be extended. And now the pericardium is dissected from the inferior vena cava. Now the left atrium is opened. And see how good the exposure of left atrium is. And it can be applied even for the small LA. And this is the, after removing the valve, it is inspection of the anterolateral and posterior medial papillary muscles. And now the annular sutures, the Ethibond 20 Ethibond sutures which are taken to the annulus, they are taken from the papillary muscles. And now the sutures are taken out from the annulus at each commissure. So like posteromedial papillary muscle will go to the medial commissure, anterolateral papillary muscle, it will go to the lateral commissure. And rest of the annular stitches are in the similar fashion of any regular mitral valve replacement surgery. Now we pass these sutures from the prosthetic valve. Except for the commissural sutures, everything is tied first. And later on, after checking the papillary muscles through the valve, we will gently tighten it. Now, In the post-operative 2D echo, what we analyzed is left ventricular end systolic diameter, end diastolic diameter, and the end systolic and end diastolic volumes, and ejection performance, as in ejection fraction and fractional shortening. So this is the pre-operative 2D echo, and this is the immediate post-operative 2D echo. You can see the difference in the reduction of the left ventricular size. And this 2D echo picture shows the left ventricular outflow tract, LVOTO. And this is where we did DVR. This is a view from the aortic wall, from the aorta. You can see the mitral prosthetic wall, and there is no obstruction in the LVOT also. Most of our patients are having rheumatic pathology, and average cross clamp time was 19.29 minutes. Average CBP time was 44.96 minutes, and there is significant reduction in the left ventricular end diastolic diameter and left ventricular end systolic reduction. And when it comes to ejection performance, there is not much change in the fractional shortening and not much change in the LV ejection fraction during the 1 year follow-up and during the 1 month follow-up. I didn't include the results of immediate post-op surgery to exclude the adrenergic drive, which causes changes in the left ventricular ejection fraction or fractional shortening. So to conclude, our technique preserved left ventricular geometry by decreasing the end systolic volume, diameters and volume, etc. And there is no significant change in the ejection fractions. There is decreased aortic cross clamp time, decreased CBP time, overall surgery time. So the cost of surgery is less, and we didn't use any CB4 sutures. The cost is significantly decreased. And this technique can be applied to any pathology where wall could not be spared. And this is technically easier. Thank you.
Dr. Vansidhar,
Sir.
Your approach is through conventional approach,
Yes,
through
sir.
LA.
Yes, sir.
And you didn't cut these papillary muscles.
No,
Cordy, papillary muscles remain intact.
Yes, sir. They will
You
be intact.
didn't cut these papillary muscles.
No, sir. We will cut the cord. Valve and chordae are removed, sir.
Removed. Then what is the advantage to put suture through this papillary muscle head?
To preserve the ventricular geometry, sir.
Ventricular geometry is how the valve size will be lesser than, and there is chances of stuck of valve leaflet.
So actually, the papillary muscles were mobilized to the commissure, sir. Actually, they won't lie in the natural anatomy. They won't lie near the commissures. We mobilized it to the commissure levels, and we fixed the valve so that there won't be any obstruction or reduction in the valve size.
Then the LV cavity reduced in size, ne?
No, sir. That is
If you pull this
Yes, sir.
papillary muscle,
Yes, sir.
then the size will be reduced.
Slightly reduced, sir. Slightly reduced.
Then there is no arrhythmias, post-op arrhythmias.
No, sir. We didn't find any. Post-operative course for every patient was good only.
Any questions from audience? Okay.
Thank
you. Next speaker, Tini. So I think this was the last paper of this session. So thank you very much to all the speakers and all the audience. Thanks to the organizing committee and thanks to those who assisted us. With this, we close this session in Hall C, and today is the last paper of today. Thank you so much.
Thank you, sir. I would like to call our free paper presenter to the stage to collect his photo memento. Dr. Anirudh, sir. Education isn't something you can finish, said by Dr. Isaac Asimov. We have now reached to the very last of our explicit 4 days IACTS conference. I hope each and every one of us must have gained a lot from this opportunity. I would like to thank all the participants and to congratulate all the organizing members and our honorable moderators for the success of the program. I would like now like to request all to proceed to the hall A for the valedictory function. Thank you.